And in a manner of speaking, the transversus abdominis and the diaphragm are actually continuous. Now, by common sense, diaphragm inserts on the inside of the trunk, right? So similar thing, the TA originates on the inner aspect of the rib cage and it stays there for its entire course. The TA also does something funny. I told you at the very beginning, I want you guys to forget certain old simplistic diagrams. That's because the simplistic diagram of all three flank muscles lateral to the semilunar line does not hold true in practice. What we actually see is a medialization of the muscular belly of the transversus abdominis. You can see there's a muscle belly, there's an aponeurosis, and this little line is the musculo-aponeurotic line of transition. You can see it kind of disappears away behind the rectus, and with the rectus muscle taken away on the opposite side, you'll see it almost, this line of transition comes to the midline in the vicinity of the xiphoid. If you look at it in cross section really high up at T12, the TA is lying right behind the rectus abdominis muscle. And as one moves down L1, L2, L3, L4, L5, the TA with this blue dotted line moves a little more lateral. And in the lower parts of the abdomen, this sort of a picture that we are so used to is holds true, that there's a rectus abdominis, there's an anterior posterior sheath, and all three flank muscles are lateral to the semilunar line, which is in this vicinity over here. But higher up, the TA has a posterior overlap with the rectus abdominis muscle. That's really, really important. This is another diagram just to hammer home the point. So similar, external oblique, internal oblique cut away. You are seeing the transversus abdominis. You are seeing its aponeurotic section. And this is one musculo-aponeurotic line of transition, and this is the second. So you can see essentially it forms a namaste that is meeting somewhere in the epigastrium. And a little later, I'm going to tell you how we exploit this almost midline meeting of the bilateral transversus muscles. If I superimpose the rectus abdominis on this, it'll become very apparent that if I want to divide the transversus abdominis, I need to do it over here because thick muscle, so easy to identify. When I apply electrocautery over it, it's going to twitch. As you move lower down in the abdomen, this entire thing becomes my aponeurotic. So this is the posterior sheath as we know it. It's obviously deficient below the arcuate line. But if I want to divide, I would start very high up in the epigastrium. All right. So now that we have our lines covered, let's move on to spaces, because that's what the title of the presentation is. It's connecting spaces. So wherever there's rectus muscle, there has to be a retrorectus space, correct? Absolutely right. So this is the right and the left space on your screen right now. But what is this that is separating it in the midline? This is the linea alba. Remember, the rectus is contained within the anterior and the posterior rectus sheath. So in the midline, absolutely in the midline, there's no retrorectus space. All right. Now, logic will tell you that wherever there is peritoneum, there should be preperitoneal tissue, right? Or there should be a preperitoneal plane. But there are only certain parts of the abdomen where you can, as a surgeon, really exploit the preperitoneal or extraperitoneal tissues. And in eTEP, we exploit the two triangles that you're seeing on screen right now. Lower down, this green triangle is between the median, the medial, and the lateral umbilical ligaments. This is the fatty preperitoneal space for inguinal hernias that we are so used to in our TEPs and TAPPs. And we know that the space becomes less voluminous as you approach the umbilicus, right? That's the reason why it's triangular in appearance. Higher up, we have the falciform ligament. It has a broad base high up towards the diaphragm, and it again kind of becomes narrower and narrower as you move towards the umbilicus. So when we talk about preperitoneal tissues that you can use in eTEP surgeries, it's almost these two triangles. Now, important point, see how the triangles are having an overlap with the retrorectus space. I'm going to be coming to that in the technique section a little later. The other thing is, wherever there's transversalis fascia, there should be pre-transversalis plane, right? You're absolutely right. But where do you exploit it? It's not going to be easy to exploit in the midline or in the paramedian space. We exploit it in the vicinity of the semilunar lines and beyond. So at the very end, when I talk about spaces, you are left with this hodgepodge collection of different spaces that you somehow have to land up connecting with each other. Let's take a look at the anterior abdominal wall from a posterior viewpoint. All right. So I told you guys the transversus and the diaphragm are almost continuous with each other. So see here, another diagram from Netter's, great artist. The transversus abdominis is almost continuous with the diaphragm. It goes on the inner aspect of the rib cage. That is very apparent now. The rectus on the left side, the rectus on the right side. And for those of you who do TEPs and TAPs, this entire lower abdominal anatomy is going to be very clear. This is the median umbilical ligament, the medial ligament, and of course the lateral umbilical folds. All right. Now, again, wherever there's rectus, there's going to be retrorectus space. So easy to imagine that. This is the preperitoneal tissue in the vicinity of the falciform that we're going to be using high up. Lower down, this entire triangular extraperitoneal fat is continuous with the cave of Retzius between the pubis and the bladder. The lateral extent of the space is the deep inferior epigastric vessels that you can see on your screen right now. Now, lateral to the inferior epigastrix is the space of Bogros. And I know we only think about the space of Bogros in inguinal terms, right? We only talk about it in taps and teps. The lateral space is the space of Bogros. Well, technically, that space goes up to the diaphragm. It's just that we don't usually land up going really high over there, but the space is available and it mirrors the pretransversalis plane that I was speaking to you guys earlier about. Now, something nice happens to this space that is expected and is going to make your inguinal cases a lot easier when you're doing TEP, TAP, eTEP. It does not matter. You just need to realize that this extraperitoneal space lower down in the abdomen is dumbbell shaped. So it's easy to open up and easy to expand in the midline. That's a cave of Retzius that's in the center of the screen. And then somehow in the vicinity of the deep inferior epigastrix, you can see on either side, the space is kind of a little sticky. I wouldn't say there are bands or there is an anatomical structure making the space a little narrower. I'll just say that when you are doing your dissection here, it's a little tricky to go under the inferior epigastrix. But once you cross that hurdle, the lateral space of Bogros opens up very easily. And this is something similar that we see even in our eTEP cases. Okay, so what you guys are all here for, right? How do you break down the anatomy from a technical standpoint? When we talk about inguinal anatomy, standard TEP ports, this is what you get. You have one port slightly off midline below the umbilicus, and usually two people take two midline ports, working ports. So, and this is the sort of camera view that you get. Now, for those of you who do TEP, I had this port arrangement for a really long period as well. It's very cumbersome, especially when you have bilateral hernias and the lower port becomes useless when you're placing the mesh. It's too low. It's a cramped space. The ports are too close together. You're going to be fighting with your camera person and your second instrument. A little tedious. Somebody was not satisfied with this, and that somebody is Professor Jorge Diaz, who comes to us from Colombia. He had a brilliant idea. He realized that overlap that I was talking to you guys about, the retrorectus space is continuous with the pelvic extraperitoneal space. So all he did was he moved the camera port proximally and to one side, and you, as a result of the continuity of the spaces, have a very wide panoramic view of the entire inguinal extraperitoneal space. And suddenly, because you're further back, you have a lot of freedom to place your ports as you deem fit. You can place them in the midline, you can triangulate them, you can put in an extra port if you're having a bilateral case. It gives you a lot of flexibility and much better vision. So he has hypothesized that while the learning curve for TEP is very steep, eTEP, the extended or enhanced view form of TEP, is actually going to be more easy to adopt by the novice surgeon. Let's come back to this. Okay, when we're talking about ventral hernias, I told you there's this hot mix of spaces that somehow needs to be connected, because you can't put 5-6 different meshes in each space. We need to put one big mesh. That's where eTEP comes in. How to connect these spaces is extremely important to understand. People had been coming up with different techniques. There were transabdominal techniques, there were even extraperitoneal techniques, but they were extremely cumbersome. It took one guy, Igor Belyansky, to break down the Restopa repair into an acceptable, reproducible eTEP technique. He had an amazing idea, and he was able to put all of the pieces of the puzzle together. Now, he recognized that the importance of the Restopa technique lies in the fact that there's one mesh expanse and the entire retrorectus spaces of either side need to be amalgamated. They need to be joined with each other. When we do open surgery, we make an incision on the midline. It's easy, right? And we divide the two constrictive sheets on either side and connect the spaces. But when you're doing it endoscopically, we don't have the liberty or the luxury of dividing the entire midline and then dividing the post-rectus sheath. So how do you cross over from one space to the other? So he looked at a bunch of different diagrams, and I suspect he would have seen this nice little extraperitoneal tissue in the form of the falciform overlapping behind the retrorectus spaces. And he said, I can cross over from one side to the other within this extraperitoneal tissue, right? So there are two types of crossover in general. There's a superior and the inferior crossover. When you talk about the superior crossover, this is how we go about it. We place one subcostal port. You can do it by either an optical trocar entry. I'm sure the other speakers are going to be discussing that in detail, or you can do an open entry. Either way, you're going to be looking at the rectus muscle on top and the post-rectus sheath below. So just like we would do in TEP repairs, with just a 0-degree scope or with the use of a PDV balloon, you can expand this entire space. It opens up beautifully. Remember, the rectus muscle is attached to the anterior sheath. It's not attached to the posterior sheath as such. So whatever little connections are there, they're flimsy. There's white, this fibrous tissue that we can just break open. With a single port in the subcostal region, you can open up this entire space. No worries. Okay. You put in a few working ports. You get into the median extraperitoneal space, which is this falciform, and you exploit this overlap that you're seeing between the two spaces. I'm going to show you how we do that in just a bit. You finally exploit the overlap to the contralateral retrorectus space, and you connect all of this together. So superior crossover seems easy, right? Because it is. Trust me. This is what the entire anatomy looks like in cross section. I'm sure most of you would have figured this out. So these are the two rectus muscles, external, internal, and the transversus abdominis. Note here, the transversus is quite medial. All right. It's going behind the rectus muscle over here. So we are quite high up. This is an epigastric cut section. And you can see it's the epigastrum because there's a lot of falciform over here. All right. The blue line is the anterectus sheath, which is going into the linea alba. The red line is the postrectus sheath. So you have the internal oblique giving an anterior and a posterior slip. The transversus gives it slip. And you have this connecting over here in the midline. The dotted line that you see is the transversalis fascia, but I'm just going to remove that for simplicity's sake right now. The yellow line is the peritoneum. All right. Please stop me at any point if you'd want me to cover this thing again. So I said you want to put a subcostal port between the rectus abdominis and the post-rectus sheath. And when you start insufflating carbon dioxide, this is what happens. The entire space opens up between the semilunar line laterally and the linea alba medially. Under CO2 insufflation, the post-rectus sheath, which should be flat, suddenly becomes like a wall on the medial aspect. And this wall-like post-rectus sheath is divided. Once you divide the post-rectus sheath, you're going to end up seeing the free fatty tissue of the falciform. You drop the falciform off the linea alba until such time that you can see the contralateral rectus muscle through the post-rectus sheath. If you can't see it, you can localize it with the help of a spinal needle that is inserted transcutaneously, or you can just use a small amount of electrocautery to make this muscle buzz. And when the muscle contracts, you know for sure that there's a rectus muscle there. We know the PRS is there. You'll end up dividing the contralateral post-rectus sheath. And now see, suddenly the two rectus spaces are looking like they're connecting, right? We dissect off the contralateral space just like that. And we have this nice little connection between the two spaces stretching from one semilunar line to the other. So the linea alba has now been crossed across, all right? We keep dividing the post-rectus sheath as we move caudally. And as you move caudally, the amount of extraperitoneal fat is going to keep reducing because the falciform gets thinner and thinner and has an apex as we approach the umbilicus. In thin patients especially, you may find there's no fat at all. There's only thin peritoneum. You may even land up making a rent in the peritoneum, or you may just land up making a rent in the vicinity of the hernia. There's nothing to worry about. You just suture this posterior fascia back together. Remember, you don't only have to suture the cut edges of the post-rectus sheath. You can use anything you want, including the extraperitoneal fat, the hernia sac itself, or the peritoneum. Just get a posterior fascia closed so you can properly place an extraperitoneal mesh. You don't want any buttonholes anywhere that bowel can pop through and come into contact with prolene. So if there's a superior crossover, there has to be an inferior crossover, and this is how you establish that. You put a subcostal port just like earlier. You dissect off the retrorectus space on one side. You get into the inguinal extraperitoneal tissues. You then place a suprapubic port and 2 working ports on either side. Once you've done that, you're now looking up towards the head end of the patient, and you can now access both the retrorectus spaces. And the inferior crossover is ergonomically challenging, but technically very simple. So when you are lower down, this is the sort of picture you're going to have. Your ports are always going to be in this extra peritoneal tissue. This is lower down in the abdomen. We know that because all flank muscles are lateral to the semilunar line. You're going to be lower down in the extra peritoneal tissues over here. And the red lines that you're seeing are going to be the arcuate lines. Just divide them close to the linea alba and start dissecting between the posterectus sheaths and the rectus muscle, and you're going to be good to go. So much easier to perform the inferior crossover. Just a small note, I don't like going into the exact origins and insertions and the exact course of all of the nerves. This diagram is just to hammer home the point that the neurovascular plane of the abdominal wall lies between the transversus and the internal oblique. So in all of these images, you'll see the external and the internal have been cut away. And the veins, the nerves, and the arteries, they are all lying on top of the transversus under the internal oblique. That's what the neurovascular plane is. And when we are sitting and doing all of these complex procedures, you need to ensure that the neurovascular supply of the abdominal wall is not hampered. Because if we screw this part of the anatomy up, the patient is not going to have good functional rectus abdominis muscle. So you may have plugged the hole, but now you're creating a functional issue. And the patient is going to keep coming back to you with vague discomfort, with bulges, with weakness, and that's going to be really difficult to explain long term. In cross section, this is kind of what it looks like. Really high up, again as earlier, external, internal, transversus going behind the rectus abdominis in the epigastric region, right? All of the neurovascular supply comes between the internal and the transversus, comes medial, 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 and at the semilunar line, it pierces the posterior lamina of the internal oblique over here. So there's an anterior lamina that goes to the anterior sheath and a posterior lamina that goes to the posterior sheath. And this arises just medial to the semilunar line over here. What do the neurovascular bundles do? Well, they supply all of the muscles close by, but when we see them, their final job is to supply the rectus muscle, and then they go epifacially to supply the anterior abdominal wall soft tissues. Okay, so that's the skin and the subcute anteriorly. When we want to do a Reeves Stopa repair, the retrorectus spaces are amalgamated. Now, the lateral extent of the retrorectus space is going to be the semilunar lines that we had discussed in the first part of the presentation. So if you want to put in a mesh, it's going to kind of be in this shape. This mesh expanse is okay when you're treating a small hernia, say a 5 by 5 centimeter defect. Everything will close pretty well if the patient is not having a high BMI, and you're going to be satisfied with a mesh overlap. But what about when you have very, very large defects? You can still attempt these eTEP, but I can guarantee you the mesh overlap is not going to be satisfactory and the defects are not going to close well. So you're going to need added component separation. A lot of people did a lot of different things. This is from Carbonell's paper in 2008. What he used to do is he used to divide the posterior lamina of the internal oblique over here and dissect between the internal and the transversus. So he could go beyond the semilunar line, which is at this level, and place a wide mesh for large defects. But remember, I just told you the neurovascular supply or the neurovascular plane of the abdominal wall is between the transversus and the internal oblique. So Carbonell said that he didn't have any functional issues in any of the patients that got operated this way, but the technique didn't get adopted because it was not in line with our anatomical and surgical understanding of the abdominal wall. And this didn't, become very fashionable. And I think he's the only guy who actually published this sort of a repair. But we were in search of better procedures that could allow us a wide mesh placement in the retromuscular space. Yuri Nowitzki is one such man. He practices around New York. We owe him a lot of things. His initial foray into large ventral hernias involved dissecting a preperitoneal space, open. Those of you who have gone and done preperitoneal repairs know it can be extremely challenging. And while you may get the entire space opened up for yourself to place a wide mesh, it doesn't give you any medialization of the defect. So for large defects, you're still going to be struggling to close. Yuri, of course, had a very bright idea to overcome all of these difficulties. He realized from cadaver studies that the transversus muscle extends medially behind the rectus abdominis, very high up. So he came up with a posterior component separation technique that we now understand as a transversus abdominis release. How does he go about it? It's pretty simple, really. The first part of the dissection is like an open restoper repair, okay? Or when you're doing eTEP, it is going to be the same thing. You get into the retrorectus space, you do the crossovers, you create a white space between semilunar and semilunar line, okay? Now you want added medialization of the fascia. You want to be able to place a large mesh. The first thing you do is visualize the neurovascular bundles, very easily visible. You go medial to that and divide the posterior lamina of internal oblique. Once you do that, this thin fascia, you'll be able to see the muscular belly of the transversus abdominis underneath. You can take this down with any energy source you desire. You can use monopolar on a hook, you can use ligashore, you can use harmonic, you can use bipolar, vessel cutter, sealers, whatever catches your fancy. Just be sure to divide only the transversus muscle and do it medial to the neurovascular bundle. So they are safeguarded. So you're not messing around with the functionality of the rectus abdominis. Once you've divided the muscle, you actually circumvent the most difficult part of the preperitoneal plane. Again, those of you who've gone and done preperitoneal repairs know that the lateral preperitoneal plane opens up very easily, but the median and the paramedian plane just behind the posterior sheet does not open. And guess what this repair has done? This repair has bypassed all of the difficult parts of the preperitoneal repair. You immediately go into the lateral space of Bogros. Sorry, just one sec. Yeah. So you suddenly have entry into the lateral extraperitoneal space of Bogros, and you have medialization. How much medialization do you have? You have more than 10 centimeters medialization of the entire posterior complex. The posterior complex is going to have this posterior sheath, it's going to have the peritoneum and the transversalis fascia. Not only that, you get up to 10 centimeters medialization of the anterior complex that consists of the rest of the anterior abdominal wall, which is most of the transversus abdominis, the external internal oblique, and the rectus muscle. Now, you can imagine component separation in the form of a weight that is suspended from the ceiling by means of 3 springs. The weight is going to stretch the springs down to a certain level and it's going to stop, right? If I disconnect one of the springs, the other 2 springs are going to stretch that much more under the same weight. So over here, when you've disconnected the transversus insertion, the other 2 springs, which are the external and the internal oblique, stretch that much more. So you have this myofascial medialization. Now, as a result of all of these maneuvers, particularly the transversus abdominis, see what we've done. Our first part of the procedure was the eTEP RS. So we were connecting the retrorectus spaces going behind the linea alba without damaging it through these extraperitoneal tissues. You could do a superior crossover, you could do an inferior crossover. By doing a TAR, you can actually go beyond the semilunar line into the lateral extraperitoneal space of Bogros. When you combine all of these spaces, you actually have a very massive extraperitoneal plane that you are free to put very large meshes in. In an open surgery, we've started putting 45 by 45 and 50 by 50 centimeter meshes. I know Dr. Gandhi has put in a massive new mesh in these past couple of weeks in an open repair. But trust me, even in eTEP TARs, we are routinely putting in 30 by 30 meshes without any trouble at all. And when you have a huge extraperitoneal plane like this with huge macroporous meshes, you are truly performing giant prosthetic reinforcement of the visceral sac, something that was taught to us way back in residency. But this surgery or this form of surgery is a true, how do you say, practical application of that concept. Thank you so much.
Thank you so much, Dr. Ahem. It was a fantastic presentation and very impressive line diagrams. I'm sure any PGs watching it, it was a live demonstration how to present. And I especially like the new conceptualization of the abdominal wall anatomy that you very vividly described. So thank you once again. Thank you very much. And we will of course have the questions at the end. And we now actually move on to next speaker, the next topic for today. Who And I invite Dr. Rahul Mahadar, who is a consultant GI, laparoscopic, bariatric, and abdominal wall reconstructive surgeon from Mumbai. He is the owner and medical director of Jeevan Sri Hospital, Mumbai. He is trained at various national and international centers, and he himself is a trainer at Ethicon, Covidian, and CMAS institutes in Mumbai. He has a vast experience of 20 years and has several publications to his credit. He will discuss the indications and technique of eTEP applied to groin hernias. Over to you, Dr. Mahadar. Please start sharing your screen. And I hope Dr. Aham has already stopped sharing his screen.
Yeah, I have.
Can you see my screen now?
Yeah, it is very well visible, sir. Please proceed.
Yeah. So thank you very much for giving me this invitation. And we will discuss about this eTEP technique for the inguinal hernia. Now, TEP technique is the closest to the ideal. Why? Because the abdominal cavity is not penetrated, less risk of visceral lesions, low risk of trocar site hernias, reproduces the time-tested technique of Reeves Topa, and gives the unsurpassed view of inguinal region for dealing with the hernias. Just 1 second. I'll just 1 second. Okay. So drawbacks of classical TEP. It is limited to surgical field, restricted port setups, and possible intolerance of pneumoperitoneum. Especially, all these things are evident in short distance of umbilicus to pubic tubercle, incarcerated sliding hernias, large inguinal hernias, previous pelvic surgery, and obese or post-bariatric patients. So the eTEP technique is based on the anatomic that extrapolates can be reached anywhere in the abdominal wall. Here, E stands for enhanced or extended view. I am Dr. Rahul Mahadar today in front of you giving the narration regarding the eTEP for inguinal hernia. Now, Jorge Dias from Colombia, he has invented this particular technique. And what he has believed the work will begin is half done. So what he does is the standard laparoscopic inguinal hernia repair was done by the standard port positions in the midline. That is optical port in the umbilicus and the 2 midline ports in the midline. And we can deal with the either side by standing either side. What Jorge Dias did is he has shifted this optical port way above and lateral to the anterior abdominal wall. And he's also shifted the 2 hand instruments, one from the umbilicus and one from the lateral abdominal wall. Because of this, what has happened is even the ergonomics is well maintained. And because of that, you can deal with the large hernia also because you get a larger space to deal with. And then because of this, there are several advantages. We are going to see it one by one. Now, eTEP has a salient features. First is a fast and easy creation of extraperitoneal space, creation of a large surgical field, then flexible port setup, which is adaptable to any surgical census, tolerance to pneumoperitoneum, then easy paralyzation of the cord structures, that is a dissection of the hernia sac and from the cord structures, and easier management of the distal sac in the cases of large inguinal hernias. And the eTEP, for the eTEP inguinal hernia repair, the surgical applications are, it facilitates surgeons in an extraperitoneal approach. So moreover, maximum number of the inguinal hernias that can be dealt with the eTEP technique. And the previous pelvic surgeries, wherein we used to do a transabdominal approach, there also you can use an extraperitoneal approach. The complex cases, wherein there are 2-3 cases, 3 types of hernias together, that also can deal with this. Lumbar as well as the ventral hernias that can be deal with this eTEP approach, and obese and post-bariatric patients. So key technical aspects of eTEP are, first is high camera port placement, that is way above in the anterior-abdominal wall. Then flexible port distribution. Now, what is the mean by the flexible port distribution? Flexible port distribution means you can put, if required, one another port or extra port that can facilitate for you for the dissection. Also, the maintaining the extraperitoneal space. So, without causing any trouble, you can deal with the complex cases. Then division of the posterior fascia or arcuate line. So this is a key feature, how I will show you. And once you divide this posterior fascia, which is not there, which is not done in case of a tape repair. And this is the main key point of a eTEP. So division of a posterior fascia is the key feature of a eTEP for inguinal hernia repair. And once you do it, you can get a large space and you can maintain the pneumoperitoneum also, even though you have done or punctured or you are inadvertently rented the peritoneum. Still, you can maintain the space and you can still go ahead and do the dissection. And ease in a hernia repair, that is evident specifically in the large inguinal-scrotal hernias. High camera focus. Is above in the anterior-abdominal wall or either in the flanks also. So from the flanks also you can deal with this, or otherwise from the upper quadrant or in the anterior abdominal wall. So you can see here for the right side inguinal hernia, the port positions are like this. You can see my cursor. This is the optical port, and this is the umbilical port through which a 5 mm trocar is going, and this is a lateral port. And from these two hand instruments, we are dealing with the for the right side hernia. The optics is coming from here. Ergonomics is well maintained. Now, for the left side hernia, you can put another port here, and you can put these two ports as a hand instrument and deal with the left side hernia, and the optics will remain here. Or otherwise, if you have INOX, then what you can shift it here, and these two lateral ports can be utilized for the hand instrument, and ergonomics is well maintained, and still you can deal with the left side hernias as well. Now, for doing this particular eTEP repair, one has to know that with the rectus muscle. Now, why rectus muscle is important, width of rectus muscle is important, because at the lateral of the rectus muscle, as Ahem has already described regarding the anatomy of anterior abdominal wall, there is a linea seminoralis. Now, this linea seminoralis is called as a Lakshman Rekha in case of abdominal wall reconstructions. Now, this linea seminoralis, why it is important? Because there are all the muscle aponeurosis, they come together, as well as neurovascular bundles, they also come together. And specifically that will be lined or that will be marked by the lateral border of the rectus muscle. So rectus muscle, the sizes ranges from 4.5 centimeters to 12.5 centimeters, and with an average of 6 to 8 centimeters. So average, you can see 6 to 8 centimeters of rectus muscle width for any human being. Now, how you can mark the seminar line? Now, seminar line is identified with the help of ultrasound guidance. Now, ultrasound, if it is available in your OR, then it's OK. But if it is not there, then what to do? Then in that cases, what we can do is where to start. And the question comes in our mind is where to start and how to decide the site of a first entry point. For this, one should know the anatomy or surgical anatomy and surgical surface marking in case where we are learned in during the lectures. So each access surface marking, I'll show here. Now you can see here this patient is having bilateral inguinal hernia. This is a midline what I am marking, and these are the costal margins on both the sides. And then this is a symphysis anterior superior iliac spine and the pelvic girdle. And the inferior epigastric vessels, these are prominent as this is a thin patient. You can see prominently the inferior epigastric vessels. Those are approximately 4 to 5 centimeters from the midline on either side. Now, this is a 4 centimeter below the umbilicus. You can draw a line horizontally, which will represent an arcuate line. Now, as Ahem has said, this is approximate. So moreover, we have seen that you can see the arcuate line at around 4 centimeter below the abdomen. Now 7 centimeter from the midline, which represent the linea seminoralis or either sides. So these are the markers the ventral is needed always for all the patients. Now this is the symphysis pubis. Now here you can see that in this particular patient is below 15 centimeters. It is approximately 11 centimeters. So what is important is you have to see for the first entry point. So this is marked like this. It is a 5 centimeter from the midline, lateral, 5 centimeter lateral from the midline, and 3 centimeter above is the point wherein you can take a first entry point. So this is a 5 centimeter lateral from the midline and 3 centimeter above. So this is what is called as a Hernia point for entry for any inguinal hernia repair. So if you are dealing with the right side, so your optical entry will be from the left side. If the hernia is on the left side, your entry will be on the right side. So 12 mm will be the optical entry. Then 5 mm, 3 ports you can take. 5 mm from the umbilicus and 5 mm from the lateral part, wherein you can see the seminoral and arcuate line joining this junction. At this junction, laterally, you can take these particular ports. These are 5 mm ports. Now, we can see here how we are entering inside. So after taking or deciding the Hernia point, we are taking an incision over the skin. Now there are 2-3 types of entries. First is the open entry, other is the optical entry. So I'll show you here the open entry. So after taking a skin incision, first glistening structure, what you can see here is a scarpa's fascia. Now this scarpa's fascia is a glistening structure. You should not miss it. And this can be cut with the help of a cautery or a scissor, and then you go down and you have to dissect till the point you will get a white glistening structure. So you can dissect with the help of an artery forceps and you can see a white glistening structure. This is the anterior rectus sheath. Now over the anterior rectus sheath, you have to take a incision with the help of a scalpel. Now once you cut the anterior rectus sheath, you will see the muscle, which is a rectus muscle. Now you have to split this muscle with the help of an artery forceps, and you will see again a white glistening structure. This is a posterior rectus sheath. Now this is the plane where you have to go, and you have to achieve this particular plane. So here you can put either you can put a balloon or you do first a finger dissection. So put a finger inside, and then you can dissect towards the hernia site or symphysis pubis. And then you can dissect or you can reach up to arcuate line with this particular dissection. And then you can put a balloon here. Now PDB balloon, which is available in the market. Now PDB balloon is from the Medtronic, but the indigenous balloon with the suction tip with the normal balloon, that can be also used. But here I'm showing the PDB balloon. Now this direction of balloon should be towards the opposite side. The advantage of PDB balloon is you can see from the inside skin and subcutaneous fat, then the split muscles, and then posterior rectus sheath, and then you can see the arcuate line, and then see your balloon, the preperitoneal space. So everything is under visualization with the PDB balloon, which is not there with indigenous balloon. So balloon inflation is started, and this balloon inflation will be done under the guidance of the laparoscope. So you can see from inside all the structures, those are going away, and you can see how they are going away, and you are dissecting it. So muscles are going away, fat is going down. You can inferior epigastric vessels as well, and then you can take out this particular balloon out, and you have to see that balloon is intact. There is the balloon, and then you can 12 mm sheath, only sheath that can be utilized, and you can put into a posterior rectus space, and then a CO2. Now, after starting the insufflation, you can see from inside with the help of a balloon how much you have dissected. You can see from inside this much dissection you can achieve with the help of a balloon. Now, instead of that, you can use optical trocar entry also. Optical trocar is while going inside, you can see the muscles and you can split the muscle, and then you go down and you can see a wide glistening section, that is the target site, which is posterior rectus sheath, and there you have to change the direction of the optical trocar horizontal to the patient's abdominal wall, and then you can dissect the plane with the help of a telescope like this. So telescopic dissection is done. And here, while doing the telescopic dissection, you have to do a to and fro movements. No lateral movements should be done. And this to and fro movements will give you the unsurpassed view of extraperitoneal space. Now you are dissected this particular space, and then you are entering into extraperitoneal space. Now here, see the arcuate line and the preperitoneal space dissected with the help of a telescope. Now, the first trocar entry from the lateral border of the rectus. You can see here above, the rectus muscle is ended at this point. I'm putting a needle from outside, and that needle is coming from lateral side. And this point is the line joining the seminal line and the arcuate line at the junction. Above, you can put a 5 mm trocar here into a posterior space. Now, after putting this particular trocar, you can see here the arcuate line, and now you can put a scissor from that side and you start dividing the arcuate line. So this is a division of an arcuate line or posterior Douglas's line. Now this particular division is the key point of the eTEP for the inguinal hernia dissection. Now you are doing this particular day, and this is the critical step. It requires a little bit of a patience for the surgeon and the camera person. You have to be very delicate. And once you do this dissection, you can see here the space is started opening automatically. So once you start dividing towards down up towards the umbilicus, you have started cutting it, and you can see here the space is opened up completely. Now where you have to cut is a 5 mm from above the linea alba, and there you have to dissect, and the space is open, and you are now entering into the extraperitoneal space completely. So peritoneum is going down, and you are dissecting in this particular plane. So this is the division of the posterior rectus sheath in case of an eTEP inguinal hernia repair. This is the first step. Now you are putting a second port. Now this is another advantage for the eTEP. Now here you can see 5 mm from the linea, the division of the posterior line, and you are putting now from the umbilicus the needle, and you can see the needle from inside. It is coming. See here the needle is coming inside, and now you can put a 5 mm trocar from the umbilicus. So second trocar entry also from the umbilicus. So you will achieve this. You can put a 5 mm trocar from here, and you can achieve both the hand instrument, working instruments at the beginning of the operation itself. So in case of a TEP operation, what happens is the second
Dr. Mahadar, the
yes.
video is interrupting.
So that is a problem of a Zoom. That is my internet connection is good actually, but it's okay. We'll see how we can go ahead. Now the position of the surgeon. The surgeon is standing at the shoulder end of the patient on the left side, and for the right side, for the left side hernia. Now we are putting the third trocar. Now this third trocar is the line joining the seminal line and the arcuate line at the junction. You are coming from the lateral side. The third trocar will become, and this is again a 5 mm trocar. Now if you have a 5 mm telescope also, so you can put a 5 mm telescope from this particular fourth trocar, and the position of the surgeon for dealing with this left side hernia is the surgeon is standing at the right shoulder of the patient, and the camera person at the same position. So optics are putting from the fourth trocar, as I said. So if you are putting this optics from this particular fourth trocar, then you can see from inside the posterior rectus sheath, the linea, and the optical trocar entry also. And then you can dissect this lateral aspect of posterior rectus sheath like this, which is not possible in case of a TEP repair. So this is the key point of the eTEP repair. Therein you can large space and put a larger size of the hernia mesh. And this particular optical trocar is a closure of the anterior rear incision that can be done with the help of a vicryl or PDS sutures. Now, there are problems for optical trocar entry. You can see here, the optical trocar is going inside, first the anterior rectus sheath, then the rectus muscle, then comes to the right side. That is a posterior rectus sheath, visible posterior rectus sheath. Herein, you have to change the direction of the trocar, and it makes a horizontal, and then you are entering into posterior rectus sheath completely. Now, this is the optical trocar entry. It is a very skillful thing, and surgeon has to show very patience, and he has to show the skills also for this particular entry. But there are two other entries here. You can see those. And what is the difference between these three is the PDB balloon or a blunt trocar or an optical trocar. The access is almost equivalent. Dissection is good with the help of a PDB balloon, and dissection is not good with the optical trocar. The cost is there with the PDB balloon. The PDB balloon cost is almost 10,000 rupees, and it is actually ideally one-time use, but we can use with the after ETO sterilization around 5 to 6 times. And no added cost is involved in the blunt dissection. And for the optical trocar, you have to know, you have to have the optical trocars. That again involves the cost. So optical trocar entry needs the high skills. So possible mishap in case of the optical trocar entry, those are, first is the slipping of the trocar into the anterior abdominal wall. So slip trocar, you are slipping into the subcutaneous space. Second is, while going inside, you are directly renting the posterior peritoneal, or peritoneal rent has happened. And because of this, you can see here, the rent has happened. And because of that, there is a compromised space because of the pneumoperitoneum, and it becomes very difficult to dissect into a extraperitoneal space. So beginning entry is most important, and missed trocar into a subcutaneous plane, and wherein you are completely missed, and the plane you cannot achieve, you are dissecting into subcutaneous plane only. So you have to very precise about the access in eTEP approach, and it's a dealer's choice. So incarcerated indirect left inguinal hernia patient. This is a patient who was a 65-year-old male patient having indirect hernia since last 30 years. And he came to us with the incarcerated hernia. And we are dealing with the eTEP approach. Now here you can see, while doing the left side dissection, you can see here the sac is dissected from all the sides. And we try to dissect, reduce the contents after the dissecting the sac, but it was not possible because it was adherent on the omentum was adherent in the sac structures. Then we tried to take out the complete sac down, but still it was not possible. It was almost complete hernia. So then we decided to open the sac. Now, even though we have opened the sac in the extraperitoneal space, still we are maintaining the extraperitoneal space. You can see here, I am opening the sac now, and we deliver the omentum, which is adherent, or the contents of the hernia sac into an extraperitoneal space like this, still maintaining the extraperitoneal space. Why? Because we have divided the posterior rectus sheath, and because of that, the peritoneum has gone down. And even though we have opened the peritoneum, still we can maintain the extraperitoneal space, and we are taking all the contents into extraperitoneal space, deal with these particular contents, reduce it, achieve the hemostasis like this, and then putting all these particular, now you can see here the sac from inside, the lateral side of the sac also we are showing here. See the lateral side, and this much large defect was there. Then after achieving hemostasis, we are reducing content into a peritoneal cavity now. So contents are reduced into peritoneal cavity, and then this sac is completely dissected from all the sides, and the cut part is now then is sealed with the help of a sutures or the loop. Either you can use a vicryl loop or a catgut loop as well. So this is the incarcerated left inguinal hernia that can be dealt with the eTEP approach. Now, accidental opening of the peritoneum. Now see here, I have opened the peritoneum on the both side, those two different cases I'm showing here. You can see here on the right side, the rent. There I'm using the sutures to deal with this. On the left side, you can see here while doing dissection, I have made a rent. Here you can see the rent now on the left side. So now for this particular left side rent, what we will do is see here the rent. On one side, I'm suturing that particular rent, and the other side, I'm showing the catgut loop or Vicary loop also you can use. I prefer the catgut loop here, and because it's a cost saving for the patient, so I can use here the catgut loop. So one side catgut loop and one side suturing I'm showing. So both these techniques can be utilized for doing this particular rates which are happening. But most important, what here you can realize is the extraperitoneal space. Even though this rate has happened, still it is maintained, and you can still do the dissection and carry forward the procedure in the extraperitoneal space. You don't have to convert the procedure for the and it becomes very easier for any novice surgeon. So now here is one case I'm showing. This is the beginning of my career for eTEP. Now while doing dissection, what has happened is accidentally while doing this, I inadvertently injured the inferior epigastric artery. Now here you can see I injured the inferior epigastric artery. Torrential bleeding started. This is a real-time video. You can see I have put, as I have now 3 ports. So with one port, I have catched the inferior epigastric. The distal end I have catched, most important. Because of that, I have stopped this particular bleeding. Now I can take with the other side, ask my sister, give me, now see, the proximal end is bleeding because the artery is coming from down up, not from above down. And then I took a bipolar from the sister. I asked my sister to give me bipolar, and then I put a bipolar for the proximal distal end of the epigastric, and then buzzed it. And because of that, I can achieve almost 70% of the blood loss has been reduced. And then I deal with the proximal defect also, and I can deal with the proximal side with the help of a bipolar as well. So here you are maintaining this, and the extra port is always useful for me to achieve this particular maneuver, and it requires hardly 1.5 minutes. So you have to show patience, and you can achieve complete hemostasis. So now the almost bleeding is almost stopped now, and then still I am buzzing it because still few on the proximal or the distal side there is a bleeding. Then I achieve with the help of a bipolar, or you can use here the harmonic also, or you can use a ligature, or even you can suture this particular part, and this much time you can get. And here the complete achieving of the hemostasis is been done. Now the mesh deployment. Now for the mesh deployment, here you can see you have dissected large part of the inguinal space. So you are putting a large macroporous mesh here. So macroporous mesh is more preferred, and this macroporous mesh, the size of the mesh is approximately 18 by 12 centimeters or 15 by 15 centimeters, you can see. And this much of the big size of the mesh, if you are using, then as Jignesh Gandhi always says, there's a sail in the wind phenomenon, and carrying out the mesh into the bulge after in the post-operative period, that can be prevented as you are using a bigger mesh, and this particular dissected part is been completely covered with the help of a mesh, with the help of this size of the mesh. So port placement is an attack of strategy in case of a eTEP repair. Correct abdominal plane, that is starting into the retrorectus space, is the key. And respect the angulation principle. This particular procedure respects the angulation principle. It allows the best approach to the defect. And in conclusion, if you can say, port placement is the attack of strategy, and the landmark is the linea seminaris, and developing the appropriate retrorectus space to place the port is the key feature, and allows the best approach for the defect. Jorge Dias, the master, what he says that The most difficult step in eTEP RS scar or inguinal or lumbar hernia repair is the creation of a workable extraperitoneal space. And the initial effort towards the proficiency in a eTEP is spent developing proper tricks to accomplish this particular endeavor, and perfect knowledge of anatomy, hands-on courses on cadaver models, guided mentorship, careful selection of initial cases, and preoperative marking of a seminar line and relevant anatomy all are crucial. So friends, in conclusion, in the eTEP technique has a place in an inguinal hernia repair and perhaps in a lumbar or ventral hernia or inguinal hernias, and can extend the traditional indications for the extraperitoneal approach to more complex cases, and makes it easier for novice surgeon to perform and master the extraperitoneal approach for the repair of inguinal hernias. Thank you very much.
So thank you very much, Dr. Mahadar, for an excellent presentation. The video demonstrations were really very impressive, and we've learned a lot from you. We enjoyed your talk. And now I invite Dr. Jignesh Gandhi, Professor of Surgery and Unit Head at KEM Medical College and Sheth GS Hospital, Mumbai. He was trained in robotic surgery in USA and is a recipient of the P.N. Berry Fellowship in UK. He is the section editor of the Journal of Minimal Access Surgery and is a specialty board member of the National Board of Examinations. He's a consultant GI and laparoscopic surgeon at Fortis Hospital, Mumbai. He will discuss eTEP, Reeves Topa, and transverse abdominis release TAR in ventral hernias. Subsequently, he will conduct a panel discussion on ventral hernias as well. Over to you, sir.
Thank you, Dr. Rashesh and the Ahmedabad Surgical Society. Two stalwarts before me, they've given excellent talk, and maybe in next 35-40 minutes, we're going to cover up two topics. Because you know it's a hernia today, the HSI con is also going on, and I have to probably go on to the sessions there as well. So what does the extra vowel E stand for? It stands for extended or enhanced view. So there's a lot of confusion which people keep talking about, but with my personal communication with Jorge Diaz, I have asked him twice, and he was very clear that it's an extended view or an enhanced view, but basically we are seeing beyond what we could have seen otherwise. So these two stalwarts have brought in a revolution today in the field of hernia. That's Igor Bilansky for you, and that's Jorge Diaz. Both of them have explored this E-space so that we can look into doing more and more complex hernias today. I'm going to talk about eTEP ventral, the eTEP Reeves Topas, and the extension to that is also the eTEP TAR. Indications, there are very clear-cut indications that if you have an epigastric or an umbilical hernia, which is more than 5 centimeters.
Are you sharing your slides? I'm not able to view your slides at least.
Is it? No, I'm sharing the screen.
Is anyone else able to view his slides? Because my...
can you...
No, we cannot see the slides.
No, so it's a blank screen. It's a white blank screen.
It's a blank.
We can see your cursor, but we can't see the slide.
Yeah, so let me just join again. Wait. Let me just do a new sharing.
Yeah, so initially I thought that you want to intentionally keep the screen blank and then
No.
Nice.
Can you see it now?
No,
not
it's
yet.
a blank screen. It's a
No,
blank
not
screen.
yet.
Now, can you see my screen?
No.
No.
Dr. Rahul, have you stopped screen sharing?
Yeah. I have already stopped.
Okay. Okay.
I'll do one thing, Dr. Rashesh. I'll join back again. Okay.
Yes, please carry on.
Just give me 2 minutes. In the meantime, you can carry on some discussion. I'll just leave and join back again. Okay.
Yeah, sure. So we can take this opportunity. If anyone has a question, you can type in the chat box and I will pass on the question. Dr. Priya is a co-moderator. Priya, do we have the facility wherein a person can unmute and ask the question straight away?
Yes, sir, they can unmute themselves. Sir.
They can unmute themselves. So if anyone is not willing to type the question in the chat box, they can unmute and try and ask the question, particularly pertaining to the previous two talks. If there is any pressing one or two questions, they can go ahead till the time Dr. Jignesh Gandhi is ready with his slides.
Rashesh, can I raise a question?
Yes, please,
to Dr. Madhav.
Welcome, sir.
Yeah. Thank you, Rashesh. Dr. Madhav.
Yeah.
Can you hear? Yeah. Excellent. I've been watching your videos on YouTube also from very beginning, and I'm really fan of your videos. Only thing is that I want to know your indications. Like you are a master of eTEP. So for inguinal hernia, I have seen you doing inguinal hernias from long. So have you shifted your policy for all cases to eTEP or in the particular cases?
Very nice question, actually, Dr. Dushant. I know you very well, and you are very famous in Ahmedabad, I know. And it's a very nice question. Actually, to be frank with you, what I have realized in my day-to-day practice is the distance between the umbilicus, especially in an Indian patient in my area, the distance between the umbilicus and the symphysis pubis, if it is less than 15 centimeter, I really struggle for doing TEP repair. Let me tell you very frankly.
Right.
And that was the main reason why I accomplished this particular technique. Because many a times what happens is, see, I can do the dissection, but while placing mesh, it becomes very difficult. Matlab, when I came to that particular point while I doing tape, I used to realize that now I have to spend another half an hour or 45 minutes to deploy the mesh. So that becomes very difficult. So that time I have realized this eTEP is going to give you a better option for this. So that is where my first indication for doing eTEP repair for inguinal hernia is the distance between the umbilicus to symphysis pubis should be less than 15 centimeter.
Right.
Now, how I do it? You can see me on the screen.
Can you see? I can see you. Yes, I can see you.
Now you can see here the crease, the lowermost crease of my hand to tip of the middle finger. This distance is almost for everybody. It is almost 17 or 18 centimeters. You can go home and you can.
Dr. Mahadar, sorry to interrupt, but we are not able to see you. Not everyone is able. Am I right?
Yeah. Can you see?
Yes. Yes.
Now see, the distance, the lowermost crease to the tip of the middle finger. This distance for everybody is almost 17 or 18 centimeters. So now what you can do is you can put this particular crease. Yes, now you can see. Now, Jignesh, you can see this particular thing.
This discussion later on, Dr.
Okay, we can go ahead with the slides and we can discuss with the Dr. Madhav in panel discussion. Yes.
Please.
Part. I hope you can see the screen now.
Yeah, we can see it.
Okay. So coming to that part, what does the E stand for? The E stands for enhanced or extended review. And these are the two gentlemen whom I was talking about earlier. I'm going to talk about Reeves, Topaz, and TAR. So indications, epigastric and umbilical hernia more than 5 centimeters. Usually we keep that cutoff for smaller umbilical hernias. Epigastric, we would probably not do that. Incisional hernias in the range of about 5 to 10 centimeters, because beyond that, it's a little gray zone. And lateral lumbal hernias and spigidal hernias as you grow up in your learning curve. Contraindications, hernia between 12 to 15, I would probably say that we can do an eTEP, Reeves, Topaz, TAR, which is a little controversial when you need a good expertise. But beyond 15, it's going to be very, very difficult by the laparoscopic or endoscopic approach. Obstructed hernia is a big no for that. Previous open sublay repair. So if you have for someone who has already done a Reeves, Topaz repair, obviously that's a contraindication for this kind of repair. And previous multiple laparotomies, I feel is a relative contraindication because you really need to be very expert if you want to do that. So say, for example, this kind of a hernia which I've seen during lockdown, this is absolutely a big no because this lady has got liver cirrhosis, ascites, and she's got a momentum which is stuck there very badly. This one, yes, obviously, this is a case which probably you would take up. It's about 5 centimeter defect, and I'll put in 3 ports on the lateral aspects and then go in and we can do an eTEP repair in this. So first and foremost, for all the postgraduates there, just a quick cut section. This is a posterior rectus sheath, or what we call it as a PRS. That's the rectus abdominis muscle. That's the ARS, or the anterior rectus sheath. That's the external oblique aponeurosis, external oblique muscle, internal oblique muscle, and transversus abdominis muscle. So one needs to get little familiarity to all this anatomy, because once you know that, then you can do a proper eTEP Reeves topaz or a TAR repair. The figure on the left here shows you how we enter into that space. There has been a couple of videos which you can see. And this is what happens after the crossover, that you have a combined Reeves topaz plane from top to bottom. So the most important part of this operation of Reeves topaz is the crossover when you're doing it by the E technique. So what happens is that typically this is my instrument which comes in there. I have to go to the summit or the apex of the posterior rectus sheath onto the left side of the patient, because if I go a little away from there, maybe even a few millimeters away, what will happen is that I'm going to lose on all that. And this 3 to 4 or 5 millimeter of loss of PRS on the posterior rectus sheath can lead a patient from getting from Reeves topaz directly into TAR, because on the opposite side, you will find it difficult to approximate. So one needs to be very, very careful. And all of you who are learning, my humble plea would be that create a Reeves topaz plane onto the left side, create it on the right side, and then do the crossover. You will get more and more confident. Because if you try to do everything from one side initially, sometimes if you get into the wrong plane, it will be very disheartening. So this is how the plate ports are. As Rahul rightly mentioned, that you have to go to that angle. The angulation is very, very important, because traditionally we are all used to going in that vertical direction in most of our surgeries. A word of caution in patients with diastasis. So see the figure on your right side. So if you have diastasis, always see this on your preoperative scan or an ultrasound, because once you have entered the Reeves topaz plane on this side, to do a crossover, remember that you have to travel this distance of 4 or 5 centimeters of diastasis, because if you don't understand this, I've accidentally seen people going straight away here into the subcutaneous tissue, and sometimes people have even deployed a mesh into the subcutaneous tissue wrongly. So always remember, in diastasis, we need to be very, very careful. If the Reeves topaz has to be extended into a TAR, then what we need to do is we need to cut this posterior lamella of the internal oblique, which is very well seen on the CT scan. Once you cut the posterior lamella of the internal oblique, then you go and cut onto the TAR muscle. And once you get into the TAR muscle, you get into this space where on the roof you will find the TA muscle, and on the floor you will find the pretransversalis space, preperitoneal space. So this is the right space. If you are doing a TAR, and for God forbid reason, you are seeing a muscle on the roof, on the roof as well as on the floor, you are probably between the IO and the TA. And this commonly happens if you're not used to the initial cut, because this can be very, very tricky and you can get into the wrong plane. So for an eTEP Reeves topaz, typically what you need to do is you need to have your both the semilunar line marked very, very clearly. You can do this ultrasound guided preoperatively. With experience, you can make out the bulk of the rectus and you can do that. Then you need to put I usually put in a 12 millimeter port onto the left upper side. Then I put my 2 5 millimeter ports into the 2 directions, this direction. And then my dissection goes from the caudal end to the cranial end. And what is most important is to dissect out the entire Reeves topaz plane onto one side, and then you do your crossover and go to the opposite side. So one has to follow all this sequence properly if you need to do a good eTEP Reeves topaz. The principle of crossover is very, very clear, that you bring your telescope from the middle port, you have your scissors or onto the right side, onto the left side you have your hook. So what I typically do is I use my bowel grasper on this side, I use my hook from this side or vice versa, and then I push the posterior rectus sheath down, and then I make the crossover in this direction. So your camera keeps on changing up and down as and when. So a 5 millimeter telescope is very, very useful when you're doing all these procedures initially. So invest into that. Don't try to compromise on a 10 millimeter all the time, because otherwise it's very difficult to do these kind of cases. So this is typically a patient which was given to me in one of the conferences. That's epigastric hernia there. And then these are the markings. So I'm standing between the legs of the patient. I identify my linea seminaris. Then I do my surface marking as I've shown here, plan my ports, Secondly, what is important is the patient position, the position of the trolley. My ergonomics should be very, very comfortable. And most important is give sequential compression device, give DVT stockings, because this surgery, you will be very happy doing a 4.5, 5-hour surgery, but you can risk the patient in a lithotomy to develop DVT. So be careful about it. Now, a case like this is an ideal case because in an era when eTEP approach was not available, this patient would have required 2 separate incisions, 2 different meshes, longer hospital stay, and more wound complications. But as you can see here, I have marked out my ports here. This is the way I go, and I do my crossover and put placement of the mesh. So let's see the operative video. This is typically a patient where you can see that the patient has got a paraumbilical hernia. The paraumbilical hernia is because you can see the rim of the umbilicus. This is the optical technique which Rahul was talking about. I always use this technique very, very comfortably. I use this XL trocar because it has got the sharp edge, the plastic edge which you can see. With that, you just have to lift up. And once you are into the right plane, my technique is that you go all the way down up to the eTEP plane, which we make in the groin region, because that opens up that space properly. The next step is step by step. Mind you, I just have 1 port now. The second port is coming now. Now this is the entire reach topaz plane. The Achilles heel of this operation is a crossover. So the black line represents where you're going to make the cut. The red is where you will lose the PRS. So don't go at the red line, go at the black line. I use in a blend mode of current with 30. And you can see this, I'm using in a spatula. This is a beautiful instrument. And with the spatula, I make this small burst of currents, go all along, allow the CO to go into that space. Once I have done that, I'm using the heel and the tip of the hook. And gradually now I travel a little bit because this patient has diastasis. I had told you when you have diastasis, you have to travel that much into the preperineal plane. Next is how do you identify the PRS onto the opposite side? So use this tapping technique or what we call the twitching technique. So here there's no twitch. Here you can see that there is a twitch. So this is no twitch, this is twitch. Open up there.
Dr. Jignesh, we've lost you. You're not audible. Hello? Dr. Jignesh? Priya?
Yes, sir.
Yeah, are you able to view Dr. Jignesh's video or slides?
Sir, I can see it, but it's stopped, sir.
Yeah. So it has, we've lost him.
Yes, sir. Maybe some internet connection problem from his side.
Yeah.
He's there, sir. He's muted.
Have I come back?
Yeah, your audio has come back. But
yeah, just a minute. Yeah. So there was a little connection problem. Just give me a moment.
No issues. Please proceed, sir.
I don't know why it is asking for an update and everything today for all of a sudden. Can you see my screen now?
Your screen is visible.
Okay, just a minute. I think the Zoom wants to update everything today. I don't know why. Can you see it now? Can you see my screen now?
No, your screen is not visible yet. We're still having the thumbnail view.
How about now?
Yeah, your screen is visible now. Your slides aren't.
Okay, fine. Now you can see my slides?
No, not yet.
No?
No.
I really don't know what's happening to the Zoom today.
Jignesh, it is asking for the update.
I know. For some reason, I don't know. I have not updated it today, but can you see it now?
Again, a plain screen.
Yeah, I know. I don't know why it is going wrong.
Share the desktop rather than.
I know, Rahul, but the problem is, that the thing is, it is not giving me that option because I think the Zoom is not updated.
You can open your keynote or this thing and give directly to the keynote. No, that will be agar.
I'm trying to do that as well. I'm just trying to do that.
Close other windows which are open now. That you should close it first.
Okay, just a minute. I think the technology sometimes messes up everything completely.
Yeah.
I don't know, for some reason I've never encountered this issue.
The Achilles heel of.
Now
can you? Yeah, Achilles heel, absolutely. Now can you see my screen?
Now we are seeing your screen, but it's a Zoom screen. We are seeing.
Now can you see Now can you see now?
No.
Can't see the presentation.
No. We are not seeing the presentation. Now that WhatsApp, and then.
Okay. Yeah, I know. Let me join in again, because that whiteboard again is coming up for some reason. Just give me 2 minutes. I'm so sorry. Yeah. Just give me 2 minutes. Yeah. In the meantime, I think you can carry on with your earlier discussion.
Dr. Rahul Mahadar was answering. Dushyant's question.
Dr. Dushyant. Now you can see here
routine,
the distance between distance between these two is almost 17 or 18 centimeters for everybody.
And sorry to interrupt, but those who have recently joined or those who do not relate to the question, I think it was related to your strategy of routinely doing eTEPs for all groiners. Is that correct, Dr. Dushyant?
Yeah.
Yes, sir. Please go ahead, Dr. Rahul.
Okay. So what I do is the first crease here, that crease to this particular the lowermost palmar crease, this distance is almost 15 centimeters for everybody. Now what we can do is I can put this particular. Okay.
No, please carry on.
No, please carry on, Dr. Rahul.
Okay. Yeah. But the screen is shared, so you can you see me?
Yeah, we can see you.
Okay, no problem.
Doesn't matter, sir. Please carry on.
Okay. So what is important is this distance. So when I put the palmar crease on the symphysis pubis and put it towards the umbilicus, if this particular crease, the umbilicus is below this crease, then I'm going for eTEP. The umbilicus is above this, then I'm going for the TEP operation. So that is what is my division clinically in the OPD, that I decide. Yes, I'm going for eTEP for this particular patient or other thing. And the other indications, as I have already stated in my presentation, always also the Hernia series study, he has mentioned the other indications like large inguinal scrotal hernias or indirect hernias in elderly patients many times. Because see, elderly patients having indirect hernia, it is long-standing always long-standing. So adhesions are going to be there. Believe me, there are a lot of adhesions, and to take those adhesions down, it requires a lot of space. So therein, you are always have to go for the eTEP. So that is another indication for me. So for the all indirect hernias, I always now prefer the eTEP approach, and the rest of the indications as mentioned in his presentation. That is what is my indications for the eTEP for inguinal hernias.
Right. So I have a question, Dr. Rahul. You happen to mention the Hernia point, that is 5 centimeters lateral and 3 centimeters cranial. To the
absolutely.
Entry.
Absolutely. Absolutely right.
Yeah. So what I want to ask is that is that the only point available, or there are some surgeons who enter through the palmar's point as well? Is that also an option?
No, actually, the Achilles heel for this particular entry point is to enter into a retrorectus space.
Right.
Or for the lumbar hernias, you have to enter lateral to semineural line, laterally into a preperitoneal space directly. For the ventral hernias, that is lumbar hernias, okay? But for the midline hernias or inguinal hernias, you have to enter into a retrorectus space. So if you want to go into retrorectus space, then that particular point is why this is important, because to maintain the ergonomics. Now, if suppose you shift this particular point towards midline, it is towards the lateral border of the rectus muscle as of now. But if you shift it towards midline, then what happens is you will struggle while doing the operation because your two instruments, they are not coming in a proper angle of 45. So that is what is important. That's why this point is important, or entry point is important.
Dr. Rashesh, another point I'll take here is if you go little higher up, it will be very difficult for a camera person to go laterally because your umbilicals will come in way, right? And they won't be able to show you. I think Dr. Gandhi is ready now. I think
yes, please.
We can shift
go ahead.
Yeah. Unmute Dr. Gandhi, please.
Yeah, so this is what I was talking about, the twitching moments. So once you do the twitching moment there, you can make out where exactly you're going to find that. So you can see here, this is opening up of the space there. So this is a second technical tip. And we just continue in that area, open up the space completely. The next thing I was talking about was the omentostasis. So achieve a good omental hemostasis. And the next part is then you are into the right side and the left side, we are watching from the top. And now you can see both the spaces together. It's very important that the left hand gives a good counter traction. Now what you can see in the floor is the part of the posterior sheath edge and the peritoneum. So you can avoid the PRS to PRS closure. It is not mandatory. Let me be very clear on this. You can take that bite of the peritoneum, but when you take that peritoneum, you can see here, I'm taking a fold of the peritoneum and not the edge of the peritoneum. If you take the edge of the peritoneum, it can cut through and you can have problems. The closure of the ARS now is in the site, as you can see by the reverse stitch. This becomes very, very useful and easy if you're doing it robotically. It comes up very, very well. If you have the linea alba intact in the lower part, you need not go and run all the way down. But by and large, many patients have associated rectus diastasis. So there is a very clear-cut paper which mentions that if you have a patient with umbilical hernia and rectus diastasis, you should repair the diastasis along with the umbilical hernia, because if you don't do that, then you have almost about 15 to 20 a higher chance that the patient can come back with recurrence, because the diastasis will pull onto the umbilical hernia repair all the time. So this is a closure of the defect and the anti-rectus sheath on the roof. And once you have done that, then you can measure the mesh space. So I typically use this ruler. The ruler is a little broad. Again, what I've done is I've cut it all of the edge and made it into half so that it goes easily through the port. And this is the tip of the sketch pen, the marker pen which we use to mark it, because a lot of time people ask, how do you mark it? So I remove that thing which we have done it in the childhood, we remove that. The next step is anisotropy of the mesh. So remember, the stiff side of the mesh should always come transverse and the flexible side should always come craniocaudal. Don't put the mesh other way around. The flexible side should be always craniocaudal. Then you use this rolling technique, the red carpet rolling technique. This is nicely described on my YouTube video. Put it at the caudal end, that's the tip of the mesh there. And now the second end, which has got a vicryl, you just pull it and it opens up like a carpet. This is very, very easy, because sometimes in large mesh, it becomes very, very difficult in that area to manipulate that area, and manipulation is very difficult. Ways of fixation of the mesh, the idea is that you don't want the mesh to move out. So I have used stackers, I have used glue, and let me tell you, the thing is, almost same in everything, whether you talk about plane or, the formation of seroma. I do desufflection in all the patients and then resufflate again, because you want to prevent that folding of the mesh. So always desufflate and then reinsufflate, and then depending on the hemostasis, you can put in a drain or you can avoid a drain. So this is how you do the eTEP.
Dr. Jignesh, we have again lost you, sir. You're not audible. Hello? Dr. Jignesh, is anybody able to hear him?
No, sir.
No,
His
no.
internet connection is again gone, sir.
Yeah. So can someone convey it to him?
I'm back. Dr. Rashesh, can you see me?
Yeah, we are able to see you. You're visible.
Yeah, I think that. Yeah, so what we'll do is, in the TAR video, I'm so sorry again. I think there is some internet issue at my end for some reason. I will, if you want, because we are already 5:30.
Yeah.
Should I start with the panel discussion now?
I think that makes sense. Please go ahead with the panel.
Yeah.
And then
so what I'll do is
maybe you can share.
I'll start with the panel.
Maybe you can share.
Yeah, I'll share the video for. I'll share it. I'll share it for all of you.
Yeah. So
we'll just go ahead with the panel discussion.
I'll put it on the association WhatsApp group.
Please.
Yeah. So thank you, Dr. Jignesh. Thank you very much. Despite those glitches, I believe it was a wonderful demonstration, and we appreciate that all speakers have focused on the technique and videos, because that's what is appreciated the most valuable. We now have the panel discussion. Dr. Jignesh Gandhi, would you invite the panelists, please?
Yeah, so I think Dr. Rashesh, you can go ahead. I will just set up my Zoom.
Fine. So, yeah. So we have this panel discussion on complex ventral hernias, and we have amongst the panelists, we have Dr. Rahul Mahadev, Dr. Ahem Arora, of course, the previous two speakers, and we have local faculty in the form of Dr. Dushyant Bhatt, who is a laparoscopic and surgical gastroenterologist from Ahmedabad, well-known figure over here, and Dr. Vinit Chauhan, who is an assistant professor of surgery in Department of Surgery, Civil Hospital, Ahmedabad. So once you are ready with your slides, please let us know, Dr. Jignesh.
Yeah. In the meantime, I think you can continue with the discussion.
Yeah, we can continue with the discussion. Yes. So, Dr. Jignesh, let me ask you a question. You said that you would create one side retrorectus space completely from caudal to cranial, and then will you create the same space on the opposite side, and then you will cross over?
So let me tell you what I do is, you create the space on the left side, you create the space on the right side. Once you have created these two space, what I do is I tell my assistant to use in an instrument. So what the assistant does is, from the right side, the assistant comes and he keeps the instrument at the edge of the PRS of the right retrorectus plate. So when you are seeing from the left side, what I tell my assistant is just keep on tapping this. So I'm writing on this paper and describing this as a tapping sign. So every time he taps, you can see from here. If you can't see the tap, you dissect further. Then again, you tell him to tap. So he's tapping it blindly. And once he taps and he says, you can see that tap, I tell him, open up the instrument. So he opens up the instrument like this. I just make a cut there and you can identify the crossover very easily. So this is a very easy technique. Technically, all of you can do that next time. And it becomes very, very comfortable. Just one additional 5 millimeters. So put 3 ports on one side, 3 ports on the opposite side, and just tap from one side, and the crossover will be very easy. And that's what will give you a lot of confidence.
Yeah,
absolutely. And then you open the area, and then you just open up. Yes. So the tapping sign is very, very important, and it becomes very comfortable. So this is the way you should do it. Let me just try and see whether I can. I don't know. Ahem, I'm just seeing the whiteboard again. What should I do?
Yeah, I think stop sharing, and there should be one other option in the dialog box to share the keynote presentation. If it's not open right now, I would say open it and try screen share again.
Okay.
Dr. Rahul Mahadev.
I've gone to the basic, advanced.
Yeah. I want to mention one point, is a very nice point which has been described by Jignesh for doing a crossover. This is a nice tip what he has given. The other thing is, the most important thing is I have seen in my day-to-day practices, many of the surgeons are there, when they are doing the laparoscopic surgery, they are very hesitant to put an extra port.
Additional port.
Why?
Yes.
I don't know.
Yes.
But that is, additional port. They always hesitate. So they, अरे यार मैंने extra port डाल दिया, इसका मतलब मैंने crime कर दिया. See, suppose a person is doing with the 3 ports lap cholecystectomy. If you are putting a 4th port, it hardly matters because it's a 5 millimeter port. It is not going to cause any problem to the patient, neither causing a big
It is not
plastic
going to
surgery
give
view
additional
also.
morbidity to the patient. Yes, I agree.
Yeah,
Yes.
it is not giving any morbidity to the patient. So that is most important thing. And another thing is all these ports, what Dr. Jignesh has mentioned, these can be utilized, or it will become easy for you to suture the posterior rectus sheath as well as the anterior rectus sheath. That is most important. Or reconstruction of linea alba becomes very easy with this particular technique. Thank you.
So thank you for those tips. They were really useful. And I hope the panel discussion, there are no more interruptions. Please.
Can you see it now?
Yeah, we are
Yes,
able
yes.
to now.
Okay, so all the panelists, you can probably come up with and I'll just put up random questions to each one of you. Yes, let us start with Dr. Rashesh. I think you can start off with this first case. So is this a case for eTEP RS? Yes, Dr. Rashesh.
That doesn't look like to me, although I don't do this frequently.
Okay, Rahul.
Yeah, this patient, if this patient is having diastasis, then I'll definitely go ahead for doing this eTEP RS. But if it is not, then I'll go for IPOM plus.
Okay, Ahem.
I just did one of these 2 days back, so eTEP for me.
Okay. Yeah. So what Rahul mentioned was right. For me it is this. Yeah. We need a cannon for this small hand. So probably I would not do it earlier on. But all of you are learning. The message is very clear that if you have a diastasis along with it, you will attempt this one, and then do it. The next one, can we have Dr. Dushyant? Dr. Dushyant, is this a case for eTEP RS?
I would like to see that how much is the defect size. If it is a really bigger one and looks like more than 5 centimeter, and
yeah, this is more than 5 centimeters.
Yes,
this
and
is more than 5 centimeters.
Patient also looks obese, so I think eTEP RS would be a good option for this patient, definitely.
Okay. Anyone from the panelists who wants to avoid an eTEP RS? Look at the color in the change in the skin color.
Yeah,
I'm sure that is visible on your screen.
Does not appear to be a reducible hernia, and I don't know how far is it a contraindication. But
yeah, so we discussed about that. Irreducible hernia. We are not going to do it. So very tricky situation here. What I found on the table, there was a tight constricting ring in this patient, and you can see that. Yeah, you can see that bowel, and this had to undergo resection anastomosis. So this patient had already developed a mesenteric thrombosis. Yeah. So again, a very clear-cut message that if you find that the patient has got obstruction, then you stop there. You do not go to the next step. And this case is definitely for an open surgery. Next case, again, Dr. Dushyant, a 52-year-old lady was operated in a nursing home. Very interesting. The surgeon took a lap cholecystectomy and a parabolical hernia together. Okay, together. Intraoperatively, there was bleeding, so he converted it to open surgery. The duration of surgery was almost 4 to 5 hours. Now, after 5 hours, he decides that he wants to do a mesh repair as well. So how many of you would agree doing a mesh repair when you have a very lengthy lap chole? Anyone can take this.
Yeah, Dushyant, please go ahead.
Yeah, I think this is already a complicated thing. Already 4 to 5 hours already gone, and open cholecystectomy with mesh repair is going to be again putting more hours in this. So I think you can go for primary repair at this status, and then maybe this patient can be followed for a second stage next time.
I think this is
absolutely
contaminated surgery, and
yes,
who suggest that you should not combine a clean surgery with a clean contaminated surgery, especially if there is bile spill and all. This could be a recipe for disaster, especially considering that the surgery is prolonged and the cholecystectomy is difficult. So I would back out and probably do only an anatomical repair or defer the hernia repair altogether.
Absolutely. So the surgeon continues and he does yes, Rahul.
I want to mention one point here. There are many surgeons, those are, they always say that I am doing regularly. I have done hundreds of lap chole along with the small umbilical hernias and all these things. I do agree. I have also done it. I don't deny that. I also done the cholecystectomy with hernia repair and all. But once this such type of a complication it occurs in a court of a law, there is nothing which is going to support you. So most important, the point to mention here is you have to be very confident that you are not doing any problems for this particular patient, or if you see that is there any spillage inside while doing cholecystectomy, then avoid going for doing the hernia mesh repair for that.
So Rahul, you have brought out the point very well. Let us see what happens in this case. But it's for all of us, because 80% of practice today is into nursing homes, and there you are under so much of pressure because you have promised the patient that I'm going to do a lap chole with the hernia and see what happens next. So this patient then undergoes the surgery, then the surgery continues. Day 5, now the patient starts getting fever, and now the surgeon is a little worried, and there is unhealthy granulation tissue because that midline wound starts opening up. And finally, this is what happens in a couple of more days. And anyone can take this, the look of this. Can you tell us what is happening? Just one quick thing.
Yeah, obviously this is in the deep SSI, and mesh has infected.
So,
but as sorry to
so the mesh is exposed, and Rashesh.
Sorry,
and Rashesh, we have all seen this.
Go ahead, sir. Go ahead.
Yes.
Hello. Hello.
No, we can't hear you, sir. Yes, tell me.
Yeah, you please proceed. I'll make my point later on. Please tell you. Continue.
Okay, fine. So you can typically see here what is happening is what we have seen on the white bread as a child in the kitchen, and this is a fungus which is growing up there. So the patient now undergoes an explantation of the mesh, and was transferred to me locally later on, and fluconazole was added to this with local irrigation. So in such cases, local irrigation with is very, very important and very useful. The patient grew Candida albicans. Now the question in this patient is, where did it come from? So again, for all of you, this is at the end of all the debridement and removal of the mesh. You can put in a wax. So lessons learned from this case is source of contamination is from the water from the overhead tank. So all of us who are practicing into nursing home setup, please watch out, because that water which you use for scrubbing, washing your instruments can harbor this fungus and can be a disaster. So 2 things can come from there. One is fungus, and the second is the atypical mycobacterium. So one needs to be very, very careful on that. And do not insert a prosthesis when you have a very lengthy gallbladder surgery. Start antifungals earlier on these patients and involve an ID. Yes, Rahul, you can make a quick point, and after that, Ahem.
Yeah. Now, one point, as you rightly mentioned about the overhead tanks. Now, another point I want to mention it here is, don't put your mesh through the 10 mm trocar what you are using for other surgeries as well. You need to use always, you can use a new disposable trocar sheets. Those are available in the market, hardly costing 1,500 rupees or 1,800 rupees. That can be used for putting a mesh inside, because the 10 mm trocar from inside is almost having the coated because of the not cleaning it properly, and because repeated handling and other things. And these harbor the bacteria,
Rahul. So
and that can be
change in the trocar. Yeah, to change in the trocar is very important. Ahem, you wanted to make a quick point? I think let's be very precise because we have less time. Yes, Ahem.
Yeah, that was actually a really good point that Dr. Mahathir, said, because all of us, we usually change our gloves. We'll use a new sterile sheet once the mesh is being introduced, but we forget that the port has been used for the entire length of the surgery, and it's all mucky inside. Another thing that I would like to hammer on is whenever, as you said, we rinse our hands with the water and we kind of feel that our hands are sterile. That's not the case. That water we don't even drink. It's unfiltered, untreated water. So always practice closed gloving, especially when you're doing hernia cases. We need to learn from our colleagues in ortho who go absolutely crazy regarding how they gown and scrub for their hip replacements and knee replacements. I think we should take a leaf out of their book. Just practicing closed gloving for these cases where skin does not come into contact with the external surface of the gown or the gloves is significantly going to reduce SSI.
Yes, Dr. Vinit, can you take?
I would like to add, sir, that if there are 2 cases, let's say there is a chole and there is a hernia, so we should always do the hernia first, and then the next case we have to do a chole. We should not do an infected case, because most of the times when put in, even in side X, then there is always a chance of infection. So do the first case as hernia, and then you can proceed with whatever other cases in our.
This case, Dr. Vineet, 48-year-old gentleman with CML, large inguinal hernia, pre-op plan. What procedure for him? What kind of procedure would you like to do for him?
This is a very, very large hernia, and looking at the picture, I would go for, in this case especially, I would like to go for an open surgery rather than laparoscopic. It is such a huge hernia.
Anyone else from the panelists want to do some different hernia?
Yeah, I would be, Dr. Rashesh, I would be concerned about loss of domain and the possible consequences of an abdominal compartment. Long-standing and
so very good point you have brought out. So the one rough way is that if it's an irreducible hernia, it's very difficult to quantify visually looking at the patient. But if the patient lies down and if you find that the contents are slightly going inside, less likely to be loss of domain. It's like what I say, that putting in a 2 kg sugar in a 1 kg bag. So obviously in this patient, what was offered was that I had taken up this patient for an open reef stopus repair because I knew that I'm not going to struggle up. Yes, with expertise now you can do even a good thing. You can do endoscopic reef stopus repair in this with a hybrid approach. But remember one thing, that when you do an open reef stopus repair, the incision in the midline which you are taking, even cover up that with the mesh. What we always do is we just look at that hernia area. This midline is always left weak. So put in a larger mesh on top of that and cover up that area, because the area where you have made the cut, and this is where you can have a recurrence. So this is one take-home message from this patient, that put in a larger mesh when you're doing a reef stopus repair. Next case, 58-year-old gentleman with right inguinal hernia, 6 months. Surgery was advised. It was deferred. Parkinson's, he was on treatment for that. He came with pain in abdomen, vomiting and distension. So he has a hernia on the right side. He has not come for the surgery, and now he suddenly comes with pain in abdomen. He's got a right inguinal hernia, which clinically is reducible, and the patient has come in obstruction. So I'm putting in the CT scan. I think apart from Ahem, everyone else can see and tell me what is happening. Yeah, so this is a CT scan of the patient. Watch it very carefully and tell me what is happening. So that's a CT scan of the patient. The stomach is huge because obviously he's an obstruction. You can see that it's into ileus. And as we keep coming down, all the time my residents were jumping and they say, sir, the right side is inguinal hernia, and sir, it has become obstructed and strangulated, and that's where the problem is. Rashesh, I'll be very happy for you also to opine on this CT scan. We keep coming down, and we can see that now slowly you will see the right groin. So the right groin of the patient comes into the picture. There's a typical picture of obstruction, dilated bowel loops. And that's now your hernia coming up there. Okay, so you'll see your hernia now onto the right side. So watch this area very carefully. That's the hernia there. So how will you proceed, Rashesh?
Yeah, is it an
that's a hernia there?
Interparietal sort of a spigelian hernia? Is that
spigelian? Okay. No, it's not a spigelian because we saw the abdominal cavity is normal. Dr. Vineet, what would you do for this patient?
Can you just, sir, can it be reversed bit, just the last portion?
I'll do that. Last bit I'll do. Okay. Yeah. So this is the last bit. We are coming down to do the pelvis. You can see air, a good amount of air into the rectum. And that's a hernia for you. That's your hernia. This is a hernia there.
So here on
the can it be a missed femoral hernia?
Yeah, it can be a femoral hernia, but then would you like to do a laparoscopic approach for him? I'll do a TAPP for him. What would you like to do?
If for this patient now, if I can go for a TAPP rather than a TEP or a eTEP, because I can easily visualize where the actually bowel is going. So I would prefer going intraperitoneal and then deciding what the hernia is, and accordingly.
Fine. Dr. Rashesh.
Yeah, I would not attempt a laparoscopy on this patient because the challenges would be immense. Dilated bowel loops. At least my surgical skills at this point do not permit me on doing a laparoscopic repair for such patients. What I would like to point out here is that the small bowel is dilated and the colon is compressed. So that gives you an idea that there is small bowel obstruction. And you are pointing out at this this area where probably there is an obstruction. So but then Rashesh,
what is surprising to me is that there is no bowel in that. Dr. Dushyant?
Right.
No
Yeah,
bowel,
definitely.
no bowel in the hernia sac. So where is the obstruction?
See, basically, I would go with the Vinay that I'll try to go intraperitoneal. I'll see what exactly going inside, and then I'll take a call. Okay, I'll put a scope inside. I'll check out the contents basically. Okay, is it a complete obstruction? Partial? It's bowel? It's not bowel. It's omentum stuck up there. It's causing obstruction. What exactly the thing is going on? Okay, then I can take a call. If it's a reducible hernia and we can do it, okay, I can proceed with TAPP. And if it is not, and the person needs anything further like obstruction or something and needs an open treatment.
No, I understand. Yeah, I understand. Yes, Ahem, your last call. What would you do?
You go up. I thought I saw some bowel being pinched a little higher up.
Okay. So if you ask me, I was not very convinced with this CT scan. And when I saw that CT scan, I said, this is something different. This is not an obstructed hernia. This is some kind of a, kind of a googly, because I'm seeing omentum there. This is omentum there. And why should an omentum in the hernia sac cause obstruction and everything there? So now let me open up the Pandora's box for you guys. So I decided that, okay, I'm going to operate this patient immediately. And with the high risk and everything which had come up, they said, okay, we cannot do it lap, or doc, you'll have to go with a small mini laparotomy. And look at this. Look at this. This was an ischemic bowel disease. And the tablet which was taking for Parkinson's, if you see the CT very carefully now, let me go back and show you the CT scan again. Okay. So if you see the CT scan again, as we keep coming down, there's something interesting which all of us should see very, very carefully. Look at the small bowel very, very carefully. Okay, so this is a small bowel coming into the view. Okay, this is a small bowel coming. Can you see this air specks into the wall?
Yeah, in the wall.
Can you see the air?
It is there.
So this is what was the problem. So the problem was that the obstruction was because of the ischemic bowel disease. So always remember, the content is a omentum. Why should a patient have obstruction and so much of tenderness? It was an ischemic bowel disease, and that was because of the tablet of Parkinson's. So Parkinson's side medications, it can cause venous thrombosis, and you can have this problem. Okay, so this was a learning from this patient. Later on, he came to me after that, 6 months settled, and then I did a TEP for him, and he was absolutely fine. But what I did at that time was I just did a tissue repair and close that ring, because I didn't want to replace the omentum with something else. So I removed the omentum, close the tissue repair like we do for a pediatric hernia, and then called him back later. So again, another case, a young male of 34. I did a bilateral TEP for him. Right was recurrent congenital and left was primary. Very interesting case again. And it was uneventful. So I was very happy that I've done a nice bilateral TEP. Few months later, he came to me and he's saying, doctor, I'm getting pain in the lower abdomen. Weight loss of about 10 kg. Obviously, because he said I'm doing dieting, because he was a little obese, very aggressive on cycling and everything. And clinically, I saw both the sides, no recurrence, because I told him to cough, absolutely no recurrence. But he was getting constant pain in the lower abdomen. And this is the area where he was complaining of pain. Okay, which was this area, and these two areas. Yes, Dr. Vinay, what do you think is going on? I've done a bilateral TEP. So the expression which you had was exactly my expression when I saw him. And typically what I do in my clinical practice is when I'm confused, I keep on auscultating the patient in all the quadrants. And while I'm auscultating the chest, I make a plan in my mind. So this is one of the tricks in private practice which you can use. Yes, Dr. Vinit.
I would like to investigate him further rather than.
So what investigation? Anything specific?
Yes, I would like to go for a CT abdomen directly in this.
CT abdomen. So everyone agrees we'll do a CT abdomen on this patient? Yeah. So CT abdomen will tell you two things. So I did a CT abdomen on this patient. The CT abdomen, so the first thing I saw whether my mesh and everything is there, and everything was intact. So he had a persistent pain, and it used to get relieved in few hours. So typically it used to say, doc, it just comes up, I get the pain, and then it just goes away. So I was just thinking whether inguinodynia, what nerve I have damaged, nothing. CT scan done, everything done. It was all looking normal. Now what next? Dr. Vinit, CT scan is normal, reported normal.
I hope
because
there is
to go for
yes. CT scan was absolutely normal, sir.
Yeah, CT scan was reported as normal because when he went, obviously he went in with an appointment and everything was done. and the CT scan was reported as normal. I had a retrospective look at the CT scan and I found it abnormal, because I'll tell you what I found. So I was quite, so I had to gather a lot of courage for this patient.
The site of the pain and the area where the pain is, could there be a small Spigelian hernia somewhere?
Exactly. So even that came to my mind, because sometimes when putting in the trocar, remember another thing learning, when we put it at an angle, sometimes we can open up that space and you can have a Spigelian hernia also coming up post laparoscopy. That can happen. So how many of you would dare now to prepare this patient for a diagnostic lab, because his pain is just not settling? He keeps on coming to you every third, fourth day. Pain ho raha hai, chala ja raha hai. Pain ho raha hai, chala ja raha hai. Rashesh, would you like to do a diagnostic lab on him?
Well, that is, yes, I think he merits a diagnostic laparoscopy, because the description of the pain looks like a colicky pain, maybe with vomiting and distension.
Correct.
If one of the reasons that would cause this is a bowel, getting entrapped in the posterior peritoneum or the rectus sheath, and a diagnostic laparoscopy may actually.
Yeah, so since I did a TEP repair, I was expecting a virgin peritoneum there. I was not expecting anything at all. So with a lot of courage, now remember, this is all happening in your private practice and you have to convince the patient. Now it's the same surgeon who is coming to. He had a lot of faith, so I said, fine, let's do it. I taking up for a diagnostic laparoscopy, and this is what I find. Look at the video. Yeah, so it's a classical case of an intersusception, and I could pick it up at the right time. And maybe when you went for the CT scan, probably it was a reduced thing, and you can see that. So the first thing I saw, and you can see that very comfortably, and that's how he used to get pain. So it is just 3 months from your surgery, and the patient again comes back to you, and that's what you see there. And then he undergoes a resection and anastomosis, and this is what I find. It's a case of small bowel lipoma. So always, first thing is point a finger towards yourself. Watch out for a recurrence, but don't miss on these tricky things, because this can sometimes be deceptive. If you don't do a diagnostic lab, I'm telling you, someone would have explored the mesh, done a triple neurectomy and everything possible for this guy, and he would have been a mess. I can tell you that. And he would have come with a gangrene. So again, something learning from this case. A 65-year-old gentleman, acute lower abdominal pain since 3 days, swelling, diabetic, hypertensive, and comes in sepsis. And this is what? So this is a lady patient post C-section. Yes, let's start with each one of them. One option, Dr. Dushyant. She comes at 8 o'clock in the evening, and now she's to be planned for a surgery. What repair?
See, first of all, her infection and everything counts, and everything need to be settled down. If she's not in obstruction.
She's toxic. No, she's in toxic and she's in obstruction, sir.
Yeah. So only thing is that to take out all the problem out, like infection and everything.
No, I agree, sir. What repair? Sir, what repair? What repair? You will make a plan, isn't it? That I'm going to do this repair, because look at the sac and everything. So we do a CT scan and everything, but looking at prima facie at this kind of a picture, what would be there in your mind? Would you do a tissue repair? Would you want like to put in a mesh? If mesh, what mesh? Or you don't want to put in a mesh?
One thing is that definitely I'm not going to put any prosthesis or any mesh in this patient.
Okay, so no prosthesis in your case.
No prosthesis.
Tissue repair with a mesh, no mesh.
I mean, it's a little scary, right? Because even if you're planning on doing a tissue repair, there's a lot of mucky soft tissue that you're going to have to pull out. If you want to put in a mesh, you definitely can't put an onlay repair. If we are feeling particularly courageous, and if you have macroporous mesh, then you put it anywhere apart from an onlay plane, and hopefully the patient does okay.
So for all of you who are watching this is ventral hernia working group classification. So classification type 1 is a clean case. Type 2, would you have a clean contaminated? Type 3 would be a clean contaminated or a contaminated case, and 4 would be dirty. So this falls in around type 2, type 3 case where you may have an omentum or a dusky bowel. There is a very nice study called the COBRA study, which talks about using in a macroporous mesh, because if you leave this patient only with a tissue repair, there's a 50% chance that these patients will come back with a recurrence. But you put in a macroporous mesh, the reason is because the pore size are more than 75 microns. So even if you have an infection with a good cover of antibiotic, you can get away with this. So luckily for me, this patient I'll just skip the CT in the event of the time. There was no time to optimize, but for me, it was all the omentum. And luckily there was just a knuckle of the bowel, which was healthy and pink. So I went ahead and I did a reef stopaz repair in this patient. So again, the knowledge of doing an eTEP, the RS, the knowing the plane. So did a eTEP, the open reef stopaz repair, put in a large piece of a macroporous mesh. But today we advent of biosynthetic mesh like physics. It can be very well utilized in this kind of a scenario. Biological mesh can be very tricky. It is used, it is very expensive. Physics is also expensive, but physics is a biosynthetic mesh. So anatomically, that mesh looks like a proline mesh, but behavior-wise, it behaves like a biological mesh. That's why it is known as a biosynthetic. So that is a mesh of choice in a scenario like this. And this patient was very happy post-operatively. She had a very nice cover of the entire area. And you can see that as I keep coming down in the section, my reef stopaz repair is holding very, very well. You can see that completely intact. And this patient had a very good recovery. This is her after 1 month from surgery. You can see that. I had operated her almost about a year back, and she's doing very well. So the message from this is, tissue repair you want to do, you can do a tissue repair, something like a reef stopaz repair. But if you put in a mesh, like a macroporous mesh, you are still acceptable because there's no contaminated or a dirty case. You can go ahead with a macroporous polypropylene mesh, good antibiotic cover, drain, and you can get good results like this. So this is what we can learn from this. And the outcomes are very well. These are the 2 papers which I was talking about by Carbonell, which talk about synthetic mesh in contaminated ventral hernia repair. Very interesting paper. You can go through that in details. Again, another case, a 52-year-old lady, Dr. Rashesh or Dr. Vinit, you can take up this recurrent hernia, okay, with previous 2 LSCs. And she has come now. So this was a case given to me in the Bangalore workshop, 7 times recurrence, okay, 7 times.
I think
so Dr. Shivram was very kind to me. He said, Jignesh, tere liye bahut acha case rakha hai. I said, very good. Yes, Dr. Vinit, 7 times recurrence.
7 times recurrence, I would suggest that first of all, this type of cases should be operated by a person who is really competent regarding these hernias. Because if again you operate the same thing and have a recurrence, I think it's a disaster for the patient.
Yes, Rashesh, you are making a point.
Yeah, that's why it was given to you, I said.
Yes, Dr. Vinit.
Yes,
Dr.
Second thing is, I would first like to go for a first, very important is the CT scan of this patient. That is the most important to exactly see
this patient,
anatomy.
So this patient was investigated, the scan was done as you have rightly mentioned. And so what went wrong? Patient factor, mesh factor, surgeon factor. So it's probably a combination of everything here. She had 4 mesh inside. So I had to look out for all those 4 meshes, which is a different topic for me altogether. But ultimately, I did the bilateral TAR in this patient because that was the plane and the right indication for this. Today, there is a new mesh available, which I have used it just within the reserve of the trials. There's a mesh which is 50 centimeter by 50 centimeters. In fact, I've just deployed 10 days back. I'm doing one more case this coming week. So you can do a bilateral TAR. So this patient underwent a bilateral TAR, and this is the same patient. In the recovery on the day 3 post-surgery, very, very comfortable. She came to me post-operatively later on with a very good results. So what the message to give to all of you, as Dr. Vinit has rightly mentioned out, these are the cases which have to be done, precautions, mentorship, and a team. It cannot be done by one alone because 7 times recurrence, something is going wrong somewhere. Yeah, so that's a very clear message which we get from this.
That was clear-cut loss of domain in this cases.
Absolutely, absolutely. Again, a patient.
Excuse me, sir.
Yes. Yes,
did you do a laparoscopic TAR or it was?
No. This patient was this was an open TAR. I'm sorry, I could not put up the picture. This was an open TAR because there were 4 meshes inside. Another thing to remember in this case is because these meshes are sterile mesh. The patient has recurrence. Patient doesn't have infection. So don't try to remove those mesh in that area and create a bigger hole or loss of tissue because the mesh is already peritonealized. So again, a learning from these cases is do not try to remove those mesh which are already there and not infected. Keep them as it is, treat the defect and you will be fine. So 55-year-old gentleman, symptomatic right inguinal with a left recurrent. So this is what the patient had. I think this was a patient with probably, I think Dr. Rahul had shared with me. And you can see that. So posterior repair, if you're going to laparoscopic repair, the dictum today is do an open repair. If you have an open recurrence, do it laparoscopic. But with experience, I think one can go ahead as you go up your learning curve. That is what we learn from these kind of cases. So this is what was from that case. Intraoperatively, you find this, Rashesh, you're doing a TEP and this is the bladder which is opened up. What will you do?
Obviously,
You
your
can see that.
needs to be repaired, and the catheter needs to be retained for a long time.
And mesh or no mesh?
Yeah, so that's the $1 million question. What would you do with a mesh? Well, I would like to actually back out, especially if I find that there is the urine is contaminated, although it is not available.
So so very good point made out, Rashesh. So again, a learning.
Dr. Jignesh, we have lost you again. Hello, Dr. Jignesh. Is anybody able to listen to him?
No.
Okay. So then again, he has to go through that cycle of
restart everything.
Yes.
Rashesh, we can continue the discussion in the about the last case, which has been. Yeah, Dr.
We are back. Yeah. Yes, sir.
Yeah. So, but this is what we learned from all these cases. Let me just see if I can show you my thing again. If not, I think we can have questions from the audience, and we can probably stop here.
Yeah, you were saying something, Dr. Dushan?
Yeah, we just it was just about the last case, which will be shown as a loss of domain. And for particularly that case, we have this bilateral TAR being done, and need little more focus from Dr. Jignesh Gandhi, that what are his indication for unilateral TAR, or Dr. Rahul can answer that. In which cases he'll go for unilateral or bilateral TARs?
So I think once you have done the Reeves-Topaz plane on both the sides endoscopically, and if you have a good peritoneal bridge in the center, close the peritoneal bridge with the rim of peritoneum fold. Don't take just the peritoneum, because you can have the manja effect there and the peritoneum can cut through. So if your peritoneum is coming close to each other, you did not bring the PRS to each other at all. Once you have done that and you find the peritoneum is also not coming together, sometimes you can use the sac. The sac can be very big, and you can use the peritoneum of the sac to bridge that area and cover up that Reeves-Topaz plane. If that is still not available, you do a TAR on one side. Because you are standing onto the left side of the patient, do a unilateral TAR onto the right side. Once you have done a TAR on the right side, again try to see this. If you find that they're coming together, you did not do the opposite side TAR. So it is always try to do Reeves-Topaz, peritoneal flap, not coming together, one side TAR, not coming together, opposite side TAR. So that is how one comes across that. Again, you can see the screen there. Again, this patient, open inguinal hernia done. I think probably we'll take it up as a last case. Open inguinal hernia done. After the hernia was done, after 1 month, the patient started coming with a wound discharge. Now look what the surgeon did. He removed that mesh, and now he put another mesh. And he said, now this another mesh is a better quality and it will work well. And he left this patient with a drain here, and the patient was moving with the drain for 6 months. Okay, 6 months. Yes, Dr. Dushan, what will you do? He comes to you now.
See, once a mesh is removed, I think it's not good idea to put a mesh at the same time again.
Yeah, but it has already been put in this case, and now the patient comes to you with this.
Yeah.
One more mesh inside.
I think we have to extend the mesh, let the wound heal. Okay, and then at the later date, once the things are done, we can go for, if it's open hernia, I'll go for TAPP, and we can put a mesh from inside.
Absolutely. So this patient was taken up. I explanted that mesh there. I sent it for cultures. Now, the most important learning point again for all of us here today from this case is, please remove the tract of the drain as well. This is like following the principle of malignancy. Don't leave the drain tract intact, because a lot of times people remove the mesh through a small incision. This is the area where I have removed the drain tract, because your organisms, which typically in this patient was an atypical mycobacteria, will always remain at the drain site. So like malignancy, remove that tract. Don't forget to do that. And this is what the patient did after the complete healing. And he did well with the dressings. But the price the patient had to pay was all these medications. The treatment today is giving clofazimine, which is used for leprosy in the past, linezolid, erythromycin, and moxifloxacin. There are a lot of regimens available. Only giving 2 months, 3 months, 1 month doesn't work. This patient needs treatment for 1 year. If you want your patient to be all right from a typical, this is a combination. So get your chest medicine team into the picture. You don't treat it yourself. Get the ID specialist. Medico-legally also you are safe, and give the treatment for 1 year. They will do very, very well. So this is what is again a learning from this particular case. And that's where we don't know whether the mesh or the surgeon or the patient or the company was with the problem. This is again another patient, very quickly to show all of you. Maybe I'll take it up as a last case. This was a patient who had a blood from my abdomen, skin graft put after a burst abdomen. Now you can see that's a hernia there. So my question to all the panelists, one by one, how many of you would like to excise this skin graft? And what repair? One quick liner. Dr. Dushan, we can start from you. Do you want to excise that graft while you're doing the repair? Look at it again.
I think he has no muscle behind this. If we can have some bridge repair or something, that would be the only thing we can do for this patient.
Rashesh, you want to sacrifice this graft, make a midline incision here, or how do you want to go about it?
Well, I think he'll need an excision, elliptical incision in any case. So why not?
You excise this.
Yeah.
But then do you think looking at this tough muscles on both the sides, this edge will come close to this edge?
No, obviously he'll need some component separation.
Yeah, but then, so again, a learning from this case is, if you have put in a graft, pinch the graft, the pinching of the graft says that the bowel inside has got released, and the pinching usually happens at 1 year. So you have to typically wait for 1 year after the skin graft to go ahead with the procedure. If you go before that, you can land up into trouble. And this is a patient where I did a TAR for him, and I went from below upwards. I didn't cut the mesh bridge at all. I kept that skin graft intact. I did a bottoms up TAR in this patient. He did very well with that bottoms up TAR. You can see here my assistants are lifting up everything. I kept that bridge as it is because this is what it helps. And look at this patient. This is a post-op picture now. Yeah, very, very comfortable. Very, very comfortable. Yeah. So again, a learning for all of us that when we have scenarios like this, what we have to do is, we have to prevent cutting that skin, because in tough patients, muscular patients, even if you do an anterior component separation, Rashesh, those two edges are not going to come close to each other. So one needs to be very, very careful. That's what we learn from all these cases. I thank all of you for your patient hearing. Sorry for the technical glitches. I'm so sorry for that, but I'll put up the videos on the YouTube for all of you to watch. Any other discussion we can have? Otherwise, I may have to leave because I've got a session at 6:30 at HSICon. Yes, any other questions?
Quickly, I would like to thank you, Dr. Jignesh, Dr. Rahul, and Dr. Ahmed have already left, and the local faculty as well. It was a wonderful discussion, very relevant, clinical, and we look forward to such meetings in the future. Actually, I'm learning a lot. We enjoyed.
Yeah, thank you
so much.
Thank you for giving us such an opportunity to,
Dr. Rahul.
Thank you everyone thank you everyone, and we will meet again hopefully.
Thank you, Neena madam. Thank you so much.
Thank you.
And the forum is now open for question, answer, and discussion. If someone has a quick question before Dr. Jignesh leaves, we have 10 minutes. So you can ask him or Dr. Rahul, anyone. You can put up the question in the chat box, and we can.
Or maybe they can even unmute themselves and ask directly. That's
Okay. Yeah, they can unmute themselves and directly ask.
Yes. Any quick question? So we have a lot of resources on the YouTube. Myself, Rahul, each one of us, we have on the YouTube, Gmail. You can always contact us, discuss one-to-one. But it was very interesting, Dr. Rashesh. We really liked it, and I really thoroughly enjoyed it. Apart from the technical glitch, but I think overall the content and the meeting went off very well. Hope to see you all in person soon in Ahmedabad. Yeah.
Definitely. In fact, we would actually like to visit your center and watch some of the work that you are doing. Excellent work you have over there. Very challenging cases, I must admit. Requires a lot of brainstorming to have excellent outcomes that you've reported. What I would like to clarify is that in one of your cases, you said synthetic mesh. So is that macroporous polypropylene mesh?
So what I was talking about in clean contaminated case is a macroporous polypropylene mesh. So you can use that very comfortably, but cover up these patients very well with antibiotics, and then that should be fine, because there's a very beautiful carbonyl study by also known as the COBRA study. So you can Google that, find it from the PubMed, and they have found out very good results with that.
What is the risk or the incidence of mesh explantation or mesh infection in these patients?
Yeah, so the mesh infection in that series which they had done, it was less than 12%, less than 12%. So maybe less than 1 in 5 patient had an explantation. So I don't think those 80% should get benefit of putting in the mesh.
Yeah, so
but yes, obviously, if you have a gross contamination, where the bowel is completely open, there's a spillage inside, or there's a contamination, I will also not put in a mesh. In such cases, then I will think about putting in a biosynthetic mesh, which is a combination of biological and synthetic together, something which is known as a P4HBH mesh or polyhydroxybutyrate or phase 6 mesh, which today is available in India, and you can use it very comfortably.
Yeah.
There is the one question from the chat box, that when will you consider it as a no recurrence after you operated for 7 times?
2 years. 2 years. 2 years, I would say, because 2 years is the time when the wound healing ends, completely stops, the phase of maturation ends. So any surgeon today who tells me कि मेरे patient को recurrence नहीं होता है, I ask him whether you have followed up for 2 years. So in my protocol, in my patient's diary, there's a first month follow-up, 3 months, 6 months, 1 year, and 2 years. When it comes for 2 years, no recurrence, I proudly say that my patient will not have a recurrence. But otherwise, this patient will keep on coming to again and again. So that is again a good question for...
I will like to add one thing in your discussion, that whenever you are operating for this type of complex hernia, ventral hernia, so nowadays we put horizontal incisions. If patient has been operated 3-4 times previously, we consider, rather than excising the scar, we consider keeping the horizontal incision. So it makes better surgery.
Yeah. So,
absolutely. Yes.
Can you, discuss how do you measure the loss of domain? I'm aware that you have to get a CT scan done and then measure the defect, and there are some complex calculations which I always forget. So in an outpatient setting,
just make the patient lie down on the bed and tell him to relax, take deep breaths. If the contents are very gradually going inside, even if you reduce 50% of the content inside on clinical examination, unlikely to be loss of domain. The only caveat is that if you have omentum or something which is stuck there and it's an irreducible hernia, then you cannot calculate. But by and large, when the patient lies down, everything going inside 50, 60, 70%, less likely to be loss of domain. So you know mentally that, okay, this patient is not going to have a loss of domain.
Yeah. And on CT scan?
CT scan, yes, you have to calculate the Tanaka's index. So if the 25% of the contents are outside, 25% are outside, then this is a loss of domain, and this patient will require either a PPP, that is progressive preoperative pneumoperitoneum, to increase the space, or you do a Botox. So that's again a very different talk. We can have a discussion on that. Once you give Botox, you paralyze the muscle, and within 6 weeks period, you have to operate this patient because that relaxation stays at peak for 6 weeks. You cannot give a Botox and operate after 2 months. You have to do it in 6 weeks time.
And in that case, you have to also excise that scrotal skin. If it is extending, reaching up to the thigh, then you have to excise that.
Absolutely. So you have to be friendly with your plastic surgeon colleague, call him with you, let him operate the case, and then take him to CCD for a cup of coffee.
Yeah.
So, sir, are you doing a progressive pneumoperitoneum, or you are giving Botox?
So at KEM, I'm restricted, so I'm doing PPP. In my private, I'm using Botox, but obviously, scientifically, both have different indications. If you see that boy, which I showed you, he had very tough muscles. We can feel that the muscles are contracted. He is a good candidate where PPP will not work because the muscles are stiff and fibrotic. The scar is very tenacious. So he's a good candidate for Botox, looking at that. The lady which we saw, that lady has got a very fluffy, spongy abdomen. She will be good for PPP. So that is how you can make out clinically which are PPP and which are for Botox.
Thank you.
Okay. Rashesh, should I leave now? Because I have to go.
Thank you, everybody.
Thank you.
Thank you so much. On behalf of us.
Yeah,
thank you so much, madam. Thank you so much. Thank you, everyone.
Thank you.
Bye-bye.
Thank you, everyone. Thank you. Bye-bye.
Yeah. Dr. Rahul, thank you very much. You are the last man standing. I must especially thank you for your valuable time. I'm sure you must be having a very busy practice over there.
Just giving a closing remark, there are 2 points I want to mention in Jignesh presentation. Actually, he has nicely presented all the cases, for the case discussion, what one should do and one should not do. Now, the last case, what he has shown in that case, wherein there is a recurrent 2 times that surgeon has put a mesh into that particular part, and he has said that drain site is also excised and all these things. So what one need to understand is, while doing such cases, how one should know that you are excised complete tract. So what one should do is just put a hydrogen peroxide and methylene blue through the tract. Right. So that while doing dissection, you know what area you need to dissect completely, and you have to take all those parts without causing air. Don't do it forcefully. You have to do it just gently, and then you can excise that particular part, and then you can do whatever Jignesh has told you. So that is one point I want to mention. Now, another point I have to mention is regarding the, you have said that where you should do a TAR or where you should not do a TAR in case of a eTEP repairs. Now, in those cases, I would say there are 2-3 points. One is the peritoneum. There is no necessity for you to take always the posterior rectus sheath. So in between peritoneum you can take, but mind well, there are 2 points again, practical points. One, what needle you are using for your suturing. That needle size matters a lot. So while closing the peritoneum, you should ask for every company which is providing sutures, there are different needles for the vascular reconstruction. So those needles are used for the closure of the peritoneum while doing the PRS closure.
And what is the
V needle? V needle.
V needle. Vascular
V needle.
Is it a
vascular
half
needle?
V8 circle?
No, you can use a half circle, no problem in that. Whichever size you want, you will feel better. You can use. But my point is, I always use either a 37 mm needle or 40 mm needle. No problem in that while using this large size needle also. But see to it that it is a V needle. Why? Because the thread wherein the goes to the needle, that part is very thin in case of a V needle. If you take a GS needle is a general surgery needle. So there, the stock part of the needle, that is the entry point of the thread into the needle, that is very broad. You got my point? So these are the things one should always notice, because what happens is, if you take a GS needle, it will cause a hole, and that hole can be tear. While you are taking the thread away, it tears off the peritoneum in between. So rather than closing the peritoneum, you are making a big hole. So that is the point where that one. Point number 2, between the 2 sutures, the distance between the 2 sutures should be less than 5 mm. It should be around 4 mm. So that if you take repeated bites of 4 mm or 5 mm, then entire peritoneum gets closed completely. So that is another point one should always remember, because many a times this peritoneum becomes very thin because there is nothing to support that particular thing. You got my point? And as Jignesh has mentioned, you can take a peritoneum, you can take the hernia sac as well. That also can be taken for the reconstruction of the posterior rectus sheath. Mind well, posterior rectus sheath is not going to support your particular repair what you are doing. The repair will be supported by the mesh. And what is the role of PRS? Is to just cover the mesh is the role of the PRS. So that is most important. So your mesh should not be exposed anywhere to the intestine or the omentum. That is what is important. So these are the points I want to make very clear, because these are the practical points one should always remember.
Yeah, another point, Dr. Rahul, I wanted to discuss over here was like when we are trying to open up the posterior rectus sheath while doing eTEP RS, particularly eTEP, Dr. Gandhi mentioned that reach up to apex. Now, if you try to go very much near to apex, there are chances that you may injure the anterior or linea alba itself, or you may injure the peritoneum over there. So it's always better to remain 2 mm away than the apex itself, rather than
excellent point. Excellent
very
point.
high up.
Yeah, excellent point.
Otherwise,
Excellent point,
like,
Dr.
it's always difficult to reach.
Excellent point, Dr. Dushyant. It is rightly mentioned. Yeah.
All right. And many right. And what is partial TAR? Like sometimes we are discussing that it's not coming up to the partial TAR.
Now regarding
halfway down.
Now regarding doing TAR, what is important is, see, what happens is you are seeing the you are done the dissection, you are done the even the closure of the linea alba, and you are seeing that your posterior rectus sheath is not coming completely, or if at all it is coming, it is very the pressure is there. It is completely taut out, and it is completed. So there is a chance that you can get immediate post-op period, even if the patient sneezes or patient even coughs. In that case, there will be an internal herniation between the mesh and the posterior rectus sheath and causing a disaster. And that needs a dire emergency. To avoid this, what is necessity is, there is a terminology called as a partial TAR, okay, or limited TAR. These are the terminology that is used. So what is it? That is important. So what is important here is, what you need to do is, you have to start dissection from down up, because as Ahem has already mentioned, in the downside, that is around just 2 centimeters above umbilicus, from there to symphysis pubis towards laterally, there is only fascia of transverse abdominis muscle, or aponeurosis, not fascia, it's aponeurosis. So you need to cut that aponeurosis down up. And once you cut only aponeurosis, don't cut the fleshy muscles on either side. First, you try it from one side, see that your the defect is closed completely. If it is possible, then it's okay. If it is not, then again from the other side, you can cut limited or partial TAR, and then you can see your posterior rectus sheath is closed enough. There is no necessity to do a complete TAR on either side or unilateral also. So that is most important.
Excellent. Do you have to close the peritoneum with the omentum sometimes, because Sarfaraz used to show that you can use omentum if you don't get peritoneum?
Yeah, that is another point wherein, after even doing a limited TAR, also many times what happens is, you see that there is little hole of around 3 centimeters or 4 centimeters is still there, and for that you need to do a complete TAR. Rather than doing that, what you can do is, you can take out the only omentum, and omentum you can suture the edges of the defect to the omentum, and that part can be seen. See, what is important, that is why I said what is important of the posterior rectus sheath is to cover the peritoneum, to cover the prosthesis. The prosthesis should not be exposed to the intestine. That is most important point. So that is where one should do it. Another point I want to mention here is, while doing TEP procedures, or even the TAM procedures also, TARM or RROM, what many of other surgeons say. So in those cases, what is important is, the midline hernias, you should see to it that all the adhesiolysis is done on the midline hernia part. Because even though the omentum is attached, you see many times what we feel while doing dissection, यार only omentum है, क्या problem है, क्यों निकालने का, रहने दो ना, कुछ फर्क नहीं पड़ता. No, because that causes restriction of mobility of the posterior rectus sheath, and that causes the closure difficult. So for that, to achieve the proper closure and without causing any pressure on the closure, one need to do a proper adhesiolysis even of the omentum also. Okay.
So now we will conclude this session. Thank you very much, everyone.
Thank you. Thank you.
Yeah. Thank you, everyone.
Thank you very much. Thank you.
Yeah. Thank you. Thank you.
Bye. See you.
Yeah. Bye. See you.
Thank you.